Myself and co-organizer, Dr. Belinda Borrelli, are very excited to invite you to this symposium. So through research talks and moderated breakout sessions, this joint symposium brings together computational and clinical investigators to push forward an agenda for bridging innovations in computing systems and innovations in health promotion and clinical research for substantial impact. We know that advancements in computing systems could transform the way health promotions are designed, implemented, and disseminated for the benefit of multiple populations. Continuous data streams collected via mobile health, such as smartphones or external sensors, can be harnessed in ways to deliver the right information at the right time, all in ways that protect user privacy and optimize treatment engagement and effectiveness. This is a joint effort between the Harari Institute's Focus Research Program and Continuous Analysis of Mobile Health Data and the Mobile and Electronic Health Affinity Research Collaborative. The Continuous Analysis of Mobile Health Research Data Among Medically Vulnerable Populations, FRP, or Focus Research Program, and the Mobile and Electronic Health Affinity Research Collaborative, or the ME-ARC, are two Boston University programs to advance digital health. The FRP is focused on developing continuous analysis and machine learning models and tools, while the ME-ARC is focused on developing and testing digital innovations and interventions to improve the health and wellness among at-risk populations. And now I would like to turn it over to Dr. Eric Heckler.
Thank you, Lisa. Really excited for this symposium. I'm going to tell you just briefly the Harari's role here. Harari Institute at Boston University is a research level institute focused on computing and data science, broadly speaking. We're a federation, a variety of other units with expertise ranging from cloud computing to security and privacy, artificial intelligence, and a whole host of initiatives that cross barriers that traditionally are impediments to progress around convergence research. Probably the most prominent one here being the one on digital health, headed by Belinda Borrelli, who will be speaking in a moment. We also bring in-house software development expertise to bear in a variety of community building initiatives. Next slide, please. So as Lisa was saying, focused research programs at Harari in general are designed to facilitate research convergence. What we do is we provide what I call scaffolding for groups to coalesce in sustainable ways. The goal is accelerating research in computing and data science, often with a partner area, for the purpose of particularly providing leveraging towards future funding and larger efforts here at BU, and ultimately broadening our impact. They are 1 year in length. They're defined by a single overarching theme, and they're typically integrating a handful of interrelated complementary sub-themes here, right? So this particular one that Lisa's speaking about and is at the heart of today's symposium, that goal is to leverage mobile health data resources for developing dynamic models privately in the cloud in a way that predict disease and anticipate changes in physiology or behavior in large cohort studies and clinical trials. And so you can see even just in those words, the multiple resources here at BU that we've been able to bring together, ranging from expertise in the behavioral sciences, electronic mobile health, to folks with expertise in cloud computing, security, privacy, and federated machine learning. So we're really looking forward to what they're going to present today, which is a culmination of the efforts of much of this year and building in turn, of course, on the efforts for a number of years now in the ME-ARC.
Thank you so much. So I would like to introduce the leadership of the Focus Research Program. As I mentioned, I'm Lisa Quintiliani, an associate professor in the School of Medicine, section of General Internal Medicine, and I focus on behavioral science intervention research. I'd also like to introduce my co-directors. First, Dr. Nicole Spartano, who is a research assistant professor in endocrinology, diabetes, nutrition, and weight management at the BU School of Medicine. And she also serves as the co-director of the Physical Activity Station at the Framingham Heart Study. And I would also like to introduce Vasya Kalavri, who is an assistant professor in the Department of Computer Science at Boston University and focuses on research which includes distributed stream processing and large-scale graph analytics. We are joined in this effort made possible by our large community of faculty members from across the university, including folks from medicine, computer science, engineering, and information systems. And now I would like to turn the presentation over to Dr. Katja Ravine, who will introduce the ARC program.
Well, thank you, Lisa, and good midday, everyone. It's such a pleasure for me to have the opportunity to learn from a collaborative interdisciplinary symposium, such as the one organized today. I'm Katja Ravine, and for those of you outside of BU, a brief introduction. I'm the founding director of the Evans Center for Interdisciplinary Biomedical Research, supported by the Department of Medicine and its chair, Dr. David Coleman. And I also direct the BU Interdisciplinary Biomedical Research Office, or BU IBRO, based at the Office of BU Associate Provost for Research. So through those entities, and along with the BU CTSI, we promote collaborative research across disciplines. And as many of you know, we do so through platforms we developed about a decade ago called Affinity Research Collaboratives, or ARCs. Next. And next. So an ARC is an assembly of investigators and trainees who develop collaborations across disciplines within BU and with outside collaborators, and with a strongly integrated educational mission. And I would say that this symposium is part of this educational mission. And so we are also very pleased that the symposium today covers the important topic of mobile health data among medically vulnerable populations, considering the Boston Medical Center patient population and the importance of addressing this challenge. Next. So at the end of the symposium, there's a talk by Dr. Atieza, who is wisely asking, digital and mobile technology for health research, nice toys or game changers? Next. I would say that we trust and hope that interdisciplinary collaborative approaches, such as ARCs, really increase the prospect of being a game changer in this domain or others. And I will end by thanking the ARC and Harari Institute leaders listed here, and affiliated investigators, of course, for their creative contributions. And I look forward to learning more during the symposium.
Hi, everyone. I'm Dr. Belinda Borrelli. I'm a professor at BU, and I'm one of the co-organizers of the conference with Lisa. And I'm director of the Mobile and Electronic Health ARC, as well as I have a role in Harari as a digital institute director. But I wanted to talk to you a little bit about the mission of the Mobile and Electronic Health ARC. And our goal is to conduct state-of-the-art research and training in mobile and electronic health to improve health across the lifespan with an emphasis on underserved and vulnerable populations. And we seek to really foster transdisciplinary collaboration so we can really be poised to answer the next emerging question or grant funding that might come out. And our goal is also to develop a scientific vision and strategy for digital health at BU. And the projects that we have have a unifying theme of hard to reach and treat populations, and using mHealth not only to help people who want to change, but also help those who don't want to change or not motivated to change. And I just want to say that we're funded by the Evans Center for Interdisciplinary Biomedical Research and the BU's IBRO office. And just the leadership team, myself, Lisa Quintiliani, Tibor Palfai, and Swati Karan, and Rebecca Mashuris, and we all represent, different departments and schools across BU, allowing for that transdisciplinary collaboration. Next slide. And we have 7 funded pilot projects and 11 affiliated projects, and they span different platforms from VR to mobile health apps, web-based intervention, social media, text messaging, sensors and connected devices. And we also span a variety of different health behaviors, smoking, diet, physical activity, and so on. We have an external advisory board postdoc and junior mentees, and many resources for the BU community. And we have a lot of BU affiliates here as well. And then on the left panel, you can see we have a bunch of different cross-cutting cores representing all different areas that you would need to involve in a digital health platform development and testing. Next slide. And so I just wanted to kick off the program today to introduce the agenda a little bit. And our first speaker will be Heather Jordan Cartwright, followed by our second speaker, Eric Heckler. Then we're going to have coffee table breakout sessions, which we'll explain in a minute, and they're organized by 4 different topics. Then we will take about a 25-minute break. And then Professor Fedor from MIT will speak, followed by Dr. Adienza, and then finally some closing remarks by both leadership teams. Next slide, please. And so here's the virtual coffee table breakout session. So when it comes time, we'll ask you to select one of the 4 Zoom meeting breakout sessions. So there are Cloud Computing Platform for Digital Health by Vasia Calvi, Digital Health Inequities, led by myself, moderated by myself, co-creation of mHealth Interventions, moderated by Lisa Quintiliani, and Synergies and Common Challenges of Mobile Health Research, Healthcare Use Cases by Nicole Spartano. And if you've already picked one and you change your mind and you want to join another one, that's totally fine. You'll get that choice. Okay, next slide, please. Okay, so I'm now going to turn it back to Dr. Lisa Quintiliani, who will introduce our first speaker.
Thank you so much. So I am delighted to introduce our first speaker, but before I do, I just wanted to remind the audience that you can please participate and ask questions using the Zoom chat feature by sending questions directly to me on the Zoom chat feature. Each BU moderator for every session will hold questions until after the presentation and then read them out loud to the speaker. So to welcome our first presenter, Heather Jordan Cartwright. She is the General Manager of Microsoft Health Cloud and Data, leading cross-organizational incubation teams in health and life sciences that identify moonshot technology and bring it to life. She founded and launched the industry's first cloud-based FHIR service into general availability in Azure, and in 2019 was recognized as one of the 50 most powerful women in healthcare IT. The title of her talk is AI and Health Data Privacy in the Cloud. Can they coexist with emerging technology? We're very excited for your presentation and invite you to share your screen now.
Fantastic. Hello, everyone. Give me one sec here. There we go. Okay. I apologize. I spend most of my day sharing screens on Zoom, so, or excuse me, on Teams, not Zoom. So it is wonderful to be here with you today. This is just a really exciting time in healthcare, and I'm so humbled when we get the opportunity to talk to people across the academic industry, because so much of the healthcare ecosystem is really about learning and the growth of science and medicine together. And today is a particularly interesting topic to me because, while Lisa certainly shared my background, I sit squarely with one foot in research and one foot in product. My job, quite frankly, is exciting because I get to identify what technology is going to be mainstream in the next really 3 to 5 years out and bring it to life. And I spent the better half of the last 7 years in healthcare, coming from many other industries, really trying to understand why healthcare is not moving to the cloud. What are some of the barriers that were preventing healthcare from scaling and health data from scaling, which ultimately was inhibiting innovation on devices. It was inhibiting the deployment of AI in healthcare. And so I want to talk a little bit today about some of the foundations that are here and some that are coming, and how collectively we can transform that. I'll start by saying there's no question we're in a paradigm shift, and there's a lot of opinions about AI and data privacy in the cloud. And I'll start with the question, can they coexist in the cloud? And so if you look historically, the answer was no. It was largely regarded by most healthcare entities, whether I talk to providers, whether I talk to pharmaceutical companies, whether you talk to critical research organizations, that the public clouds were not safe and secure for PHI data, and therefore they kept them in private clouds or kept them on-prem. I'm happy to say over the last 5 years, we have seen a release of a significant amount of technology, particularly purpose-built for protected health information in the cloud, that allows us to bring it in. So if we look today, when we look at data in store and data in transit, the answer is yes, we can in fact have health data secure and private in the cloud. But if we see some of the emerging security challenges, the emerging ability to bring massive petabyte, exabyte scale data together in the cloud and start to create links across that data set, the answer starts to become a little bit different. The answer is actually maybe. And if you sit where I sit, where you think about looking and bringing research and looking at human behavior and looking trends in the industry and how does this apply to healthcare, I actually ask the question often, when the answer is maybe, will we care? And I say that because if you look across other industries, I think about the banking industry. I remember growing up and my mother saying, I don't trust ATM machines because I want to talk to a human being when I'm dealing with money. My data isn't secure. Well, she ended up using ATM machines. Why? Because of convenience, because it's a lot easier to go to the bank 24 or to an ATM 24/7 rather than go when the bank's only open. Now, you might be saying, okay, that's fine. That's a very simple example. I wouldn't do that with health data. It's much different. But is it really? Have you traveled recently? Because I talked to a lot of people in tech that said, I'm not really willing to give up my biometric information, yet they're carrying an iPhone in which they sign in with their fingerprint, which is in fact your biometric ID. At the airport, you may look at your TSA pre-check line and say, I'm going to miss my flight. And I know myself, I ended up in a scenario 3 years ago and said, I'm ready to sign up for Clear. And just like that, I gave up my biometric eye scan, and my health data privacy was diminished. Now, it wasn't a bad thing. I gave it up in exchange for convenience and trust. I had trust in the technology. And that's exactly how we evolve. And so when you think about that, will people care about that? The way that the larger human population thinks about privacy of health data certainly continues to evolve over time. And so by the time we're actually able to do exabyte query scale in AI on this health data, will people actually be as sensitive about privacy, or will we be looking at privacy in different ways? And so that's part of the study that I think we constantly have to look at when we're working with health data is, what are the expectations for the different generations of populations, and where are we going to be in the future? Certainly, we have been in a paradigm change. In fact, I would submit to you, you are in the largest paradigm change you will experience in your lifetime when it comes to health data. It began before the pandemic, certainly, and was accelerated. I often say that COVID was the lighter fluid for health data in the cloud, because we saw three major shifts. One, we already had health data moving to the cloud. There is an estimate of about $40 to $50 billion worth of health data just sitting on-prem in operational data centers and stores. And that was making a move to the cloud, even pre-pandemic, simply because of the ability to secure that data. The ability to manage that data was becoming unwieldy for most healthcare ecosystems. With the pandemic, we had to move data globally overnight and start to identify what was happening. And so I was fortunate to be in the place where we had just launched FHIR technology and PHI ingest to the cloud. And literally overnight, we were deploying that at global scale. And so that historic shift is still happening and will continue to happen for the next several years. The other big thing we saw was the rise of virtual care and operations. Certainly for about the last 10 years, we've seen, I would say somewhat at scale, the ability to capture data from a clinical device, medical device, and push that into the cloud and to unify that. But we really haven't seen it at scale like we saw in the last 2 years. Necessity is the mother of invention, right? And so we had providers that had to talk to their patients, that had to get data coming from their chronic care patients. And they started using remote data. They started using virtual care, even though they had resisted it for whatever reason it was. I sat in front and center many hospital organizations that simply resisted, didn't trust that data. Overnight, they had to use it, and they've begun to trust it. They began to start accepting that actually maybe patients can get accurate blood pressure readings at home when I can trust the data coming in. It's enough to give me a baseline for patient care. And it has really started to transform the thought process in healthcare, because that is just as important as our ability to create technology that can capture it and machine learning that can compute around it. We need the users of that technology on the front lines to trust it and to embrace it. And so that started to happen in the last 2 years. And last but not least, we saw a complete revolution in medical publishing, and the way that we brought vaccines to market. And really what it was scientific clarity that AI-driven precision healthcare is usable, it can be accurate, and it can really accelerate the way we are caring for patients and the quality of care that we deliver. Is the only way that we were able to bring vaccines to market as quickly as we did, creating synthetic control arms in real time for vaccine development and deploying vaccines with very small number of actual people in trials with very positive results. And so that was really exciting in the world of healthcare. So what's really, I would say probably the biggest trajectory that we're seeing right now is that we've actually got unified agreement across the ecosystem. There's 6 points here on the screen. I won't read them all, but I can say that whoever you talk to in the healthcare end to end, whether that's someone on the front lines, whether that's someone that's developing medical technology or devices, whether that's someone that's running a clinical trial, data scientist, there's large agreement across all 6 of these points that we can no longer look at a single silo of data. In the care setting, we need a holistic view of the patient. There is large agreement that remote monitoring should scale. We need to create new tools for visualization. We need to get automation engaged in the front lines and the technology that we use, and we need to shorten the time to market through standards. And so I want to talk about 3 things. I want to talk about data, AI, and privacy in their own sets, because they all evolve a little bit differently. So health data, I talked a lot about health data coming to the cloud. I'll spend just a few minutes indulge in some of the tech that's out there because it's relevant. I certainly a self-disclosed FHIR evangelist. Some people love FHIR, some people can take it or leave it in the healthcare space. Fast healthcare interoperability resources. If you don't know what it is and you work with data, you should. It is open source. It is not proprietary data. It is not meant to replace what is already out there in all the hundreds of data schemas that we have. It is actually meant to unify them. It was developed by Graham Grieve, who's considered the father of FHIR almost 12 years ago. He sits in Australia and still works very heavily in the FHIR community. And some people regard it as more of a techie thing, and it's just another data schema. It's not. It's actually a framework that is meant to work with the existing schemas there that are out there today. And because it's open source, what it does is it brings them together and says, who are all the folks that are working across the ecosystem with this type of resource? They have a very finite set and small set of resources that you can say, I need another one, bring it to the community as open source. It'll evolve and review it. And we've grown from about 40 resources to about 180. And what FHIR does is it says a resource is something that will live in perpetuity, that we don't think is going to change in healthcare, but there are attributes around that resource that might change. And that's why FHIR is powerful, because it'll take something like a patient. We think there will always be a patient in healthcare. But the attributes on that patient, something as simple as, say, demographics, gender. Certainly historically, you can go to an HL7 data file and it'll say there are 2 types of gender, male and female. Well, today that's evolving. And so we want to document that differently. FHIR allows for that evolution. When the industry comes together and say, I think there should be 7 types of gender, or maybe you have somebody from the Kinsey Institute that says, I actually think there should be 20. There's that open discussion. the community comes together and we evolve the attributes for patient, but we can still exchange data at the patient level. And that's powerful when it comes to data exchange. And that's really what FHIR is about. It's about making sure that all the different data sets that are out there, all the different systems that are out there, working in whatever interface and whatever data schema that they need for that tool, on the back end, they can speak the same language. Some people often call it, and I'll also mention too, with the same API specifications for exchange, the same tools and servers. So when you talk to a FHIR server, you know what you're going to get. That's really powerful because it becomes almost USB for health data exchange. And so I often liken it to, I started my career in the automotive industry, and it's very similar to what you see in other industries where it's very complex and highly regulated, but we need a way to standardize. And it's almost like the Canbus system, if you're familiar with that in automotive. When that was invented, it basically said, look, we can't keep up with electronics in cars. The control area network allows us to say, this is what the plug-in looks like. And if you are going to build electronics for this vehicle, here's the specifications of the Canbus. You can do whatever you need for whatever system you're building, whether that's lights, whether that's HVAC controls, whether that's media, but you plug into the Canbus and it'll work. And so it really simplifies the connectivity and the interoperability for innovators and for technicians to try and build new features for the car. Same concept can be thought about with FHIR, with health data. And we are starting to see that as well in devices today, especially. And especially as we think about devices, when I started healthcare, I had the mantra that the ability to capture and annotate and apply machine learning to all the aspects of a human being, whether that's genotypical, phenotypical data, that will transform healthcare. But the reality is we don't have it all captured. What we have largely today is clinical data, and healthcare accounts for about 20 to 30% of your well-being at the end of the day. There's socioeconomic factors, and that data is captured elsewhere. So you can go to AccuWeather, and they've already done a great job documenting all the weather from my zip code that might be impacting my mental state. If I have bipolar disorder, what's going to cause triggers that might be related to the environment around me? I can go to AccuWeather already and see where there's weather pattern trends and see if there's correlation or causation. Certainly health behaviors, certainly your access to your physical environment, air quality. So we're starting to see an explosion of devices to try and capture this data. And one of the things that I have a strong hypothesis around is that if we continue down the path of using a open source and global method of exchange that is standardized, we can actually start to map these things together to create that holistic view of the patient using these medical device capture and plugging that into the health system, so we can start to really change the way that we are diagnosing patients, treating patients, and interacting with their well-being. So a little indulgent on health data services. The way that we thought about this at Microsoft was pushing beyond the envelope of just exchanging clinical data. Largely, there's three types of data when you think about the world: structured data, unstructured data, and imaging data. And we released something called the Azure Healthcare Data APIs that allows you to capture data from any structured endpoint. So maybe that's clinical data coming right out of a EHR system. Maybe that's data coming off a medical device. We looked at all the data coming off HealthKit, Google Fit, Fitbit. How do you think about the word heart rate when somebody captures it off a device? One device might be calling it HR, one may be calling it HR, spelling it out. One might be just documenting numbers, but we've actually done the work behind that to map that and organize that to FHIR standards. So you can actually take in and connect any medical device, connect it directly in and transform that data so it sits in the EHR system in a FHIR store alongside clinical data, which is already mapped through HL7 or CCDA, whatnot. We've worked with Notes APIs to think about natural language processing, unstructured data. So notes from a clinical record, PubMed publications that might be relevant to a use case. We actually do NLP over that and have trained in medical libraries, pharmaceutical libraries with our text analytics for health system and then a mapping system on the back to structure that to FHIR. So we can now see notes sitting and structured alongside structured data coming from the different repositories. And we've also pushed that with DICOM. You may want to take images and store them somewhere else, but the metadata related to images coming from your MRIs or CT scans can now be annotated and structured in a FHIR format, so you can understand very quickly where to go and find the key images that were used for diagnosis, or the key images related to certain clinical notes in a patient file. And what you start to see is a longitudinal record of that patient that then you can push to the other side of the cloud to start doing things with that data. And it almost creates a workspace, if you will, for data scientists. So they actually, and some people will call this a trusted research environment in many cases, although there's different definitions of that in the cloud. But this is really a workspace for data scientists or clinical researchers to come in and really see all the different endpoints of a patient and bring them together for whatever their use case is on the other side. To talk about that other side, there's three things you primarily do with health data today. Usually people are taking it and using it for, certainly you're using it on the transactional side. And then once you have health data APIs and a cloud store across multiple systems or in an HIE, you can start to operate transactionally in real time. And that's incredibly powerful with the FHIR framework. But if you think about AI, you're going to use it for secondary use. So you want to apply that data elsewhere. You may want to share it with another entity. You might want to visualize it for different use cases, whether that's in the operational workloads, whether it's other parts of your institution, or you may want to really start going deep with advanced analytics and developing machine learning models or applying against data models. And so coming out of that system, what we also do is have connectors to things like third-party applications. So Smart on FHIR is a technology that, especially if you are working with medical devices and the Internet of Medical Things, you should be well-versed in Smart on FHIR, because what it allows a health system to do is to protect their information within their own entity and give the whole emerging world of innovators out there access in a secure way to just the resources they need. From a security standpoint, you really want people to have access to data, but only the data they need for their use case to keep data secure. And so Smart on FHIR is an emerging technology that you can, if you've got data in that FHIR format, that you can quickly connect and allow others to innovate on your platform. You may also want to do other things like de-identification, and we'll talk about that in just a minute. You may want to connect to the many tools that are out there for visualization. At Microsoft, that's our Power Platform, Power BI, Dynamics, or you might want to connect to some of the cloud tools like Synapse. Synapse allows you to come in and you can work in Jupyter Notebook, you can work in SQL, whatever. We want to meet data scientists where they're at. And so we have very easy ways to export large sets of data and start to move it to relational tables so you can start to accelerate machine learning. And the reason that's powerful is because if you unify data in to the cloud, it really accelerates and shortens the time for model development and model delivery. And of course, if we're all working in the same format globally, which we're starting to do with FHIR format, you can see that we can start to exchange data very rapidly as patients move across the globe. And we saw that in real time with the pandemic. I happened to be sitting here in Washington State when that happened, with one of the first epicenters, if you will. And when that patient walked in, we didn't know what we were dealing with, but we quickly had to learn where that patient had traveled, what the conditions were in the locations they were at, which were not in the United States. And that data simply wasn't available. So we had to start exchanging information on how treatment was being done in different countries. FHIR allowed us to do that because we were all speaking the same language. So let's talk AI. So we can get data in the cloud, and it's unified and organized, and you may believe in FHIR, you may not. I often say FHIR is kind of the equivalent. If you have data today, a lot of CIOs I'll talk to and say, we already have that. We've got a unified database across our system, particularly at academic medical centers, because you're working with trusted research environments. I will challenge that if you aren't using interoperable standards for the cloud, it might be like a card catalog system. They're great and they work, and the librarian knows everything that's in that library. But how much more powerful is it when you can use Bing or Google search, because you don't know what got published 5 minutes ago. But the internet search was designed for that. And it's got that interoperability for anyone to contribute. And that's what really empowers innovation and future tech, is expanding the accessibility of that data. And so that's really what we're talking about when we think about this cloud technology. It doesn't mean what's out there today doesn't work. This is really setting you up for a future state where you're going to be needing to query across exabytes of data. When you think about that whole human, that is not gigabyte or even petabyte scale anymore. It's exabytes, and you need cloud technology for that. And so that's really what that whole last conversation around data into the cloud is setting us up for. So what does that AI look like? I think there's a lot of data points you can look at around AI, but it depends what type of AI you're talking about. Certainly, if you're dealing with real world evidence and life sciences, 90% of those are already in the cloud today, if not more. Most healthcare institutions are already starting to work with edge computing. I love the proof point at the bottom there from Pfizer, the CTO of Pfizer. AI algorithms were involved in every step of the way to design, deliver the COVID-19 vaccine and antiviral tablets to hundreds of millions of people that spread around the world. We see the power of AI. And so the question is, how do we scale it? Because it's not a matter of whether AI in healthcare is going to be powerful. It is. But it's not scaling. There are only just over 300 algorithms that are approved by the FDA today. And the answer of why is that there's a huge platform gap in bringing AI to market. AI today is just like data used to be, embedded in silos. So it works really well as long as you have a single system. But when you start to bring other data input, it doesn't always work, or it doesn't know how to connect. We don't have platforms to retrain it, to monitor it in new environments. So when you find a great open source model that's out there in the internet, you want to take it to Boston U, you're going to have to go through a period of training and monitoring on your own data sets. And you may not have the platform to do that today. The other thing is just trust. We talk about explainable AI. The clinical environment is not really set up for AI today. They don't trust it. They're slowly gaining trust, but even when they do have trust in models and whoever is giving them the model, we don't have great feedback loops set up. We don't have an environment on the front end of healthcare to receive that model and know that they are part of model creation, model feedback, model monitoring, and model input. That's how AI works. But healthcare today is largely, I have trusted this procedure or this model or this drug, here it is. And they execute. And so we want to transform the front lines of healthcare to start becoming more of the process as we build the ways to deliver AI. A lot of it happens today in single devices. There's a lot of AI happening in medical devices today, and we trust them. And so there's not a lot of feedback that happens. It happens kind of internally for the device manufacturers, but we really need to start collecting, just like we have it with patient-reported outcomes, we need it in the clinical environment as well, from the front lines of healthcare that are using these tools and the AI. And certainly that gap happens as well on just the basic monitoring and ensuring we're tracking for model drift, and retraining periods are automated, because those are things that make sure our AI is accurate. And there's human lives on the other side of this AI. So it's not quite like the rest of the world, where if you know, Bing Maps takes you down a different road and it takes you 4 more minutes to get to school, that's okay. But that's not okay when it's a human life and we have that measure of variance on the output. And I'll mention, last but not least, is certainly regulatory. It is hard to keep up with the pace of innovation and technology, particularly in healthcare. And you know, even in clinical trials today, to use remote monitoring, we are bucking up against legacy regulatory rules that don't really support cloud technology, cloud security that you may not be aware of if you're using cloud technology, because there's a team of 4,000 engineers doing security. Probably better to have that than one person in your organization running security on your end-to-end pipeline for a clinical trial. But the regulatory standards have not yet caught up to capture this evolution. And so that's something that has to continue changing. Talk just briefly about the AI flywheel. This is essentially how we think about how I think about the spin of where AI gets developed in the ecosystem. You may be on the front half, publishing papers. And so this is the process you take to actually hit the milestone for journal publication. But as we start to bring AI into the healthcare ecosystem rapidly, we're quickly moving towards that. We can have a go or no go into production. What does it look like? We see lots of healthcare institutions coming saying, I've got 10 models. They work with 100 people in this one clinical department. I need to scale it across my hospital system. How do I do that? And this is really where we are at today, from that evolution of bringing healthcare to the next paradigm. If you take it through the regulatory approval, again, once it's commercially deployed and other systems are using your AI model that you've developed, how do you continue that monitoring of that? How do you continue and ensure that training is being done? How do you continue and make sure that you're understanding feedback loop from those who are using it? The bias that it might be imposing on clinicians and the path they take after they look at your AI results. These are all real questions that we are researching today. And to make it more complex, there's different ways to use AI. There's do it yourself. I go back to automotive, so I started my foundation. So I use a lot of their language. Do it yourself, do it with me, do it for me, actually is very applicable to AI. So if you're a data scientist, you have access to data, you know how to use the tools, you just need an environment to work, you can grab it and go. But a lot of what's happening is really more around do it with me. We're moving from the phase of AI being only for the data scientist, and we're starting to deploy tools to help people get started faster, help provide accelerants. Like text analytics for health is a fantastic example where it's already trained in medical libraries and medical models. You may want to take that and start there if you're going to go work in oncology and train it around another elite set of data for your use case. It might be okay for what you need. But you might also be a solutions provider that's saying, I'm going to do it end to end, just plug in, and you see that certainly in devices because they do a lot of AI on the back end, just plug into my device and we'll monitor it for you. And so all three layers are very relevant in the world of healthcare. I talked a little bit about cognitive services. This is one of the emerging areas in health as we move from just clinical data typing into a computer to how do we capture data in different ways, whether it's vision, speech, language. We're training the AI models to really think about health data like the humans do and try and replicate the machine learning that is going on in the minds of the front lines of healthcare. I use this example because anyone can look at this picture and see the baby on the top and the baby on the bottom. They're the same baby. One is post-surgery when the baby was in distress, about 30 days in a remote situation at home. The parents sent the picture in. The picture at the bottom obviously is the baby in a much better baseline state 6 months later. But computer vision AI this is from a project that we did with Children's Hospital. Around remote monitoring about 2 years ago. And I still bring it back because it's just so relevant that everybody in the room can look at the picture at the baby up top and say, well, what am I looking at? When you talk to a nurse, she's going to start calling out different things. What's the coloration in the baby's limbs? What's the breathing and the way the baby's stomach is distended that indicates different, breathing challenges. These are things that we're teaching not only from imaging, but computer vision and monitoring on video that we're studying constantly in our labs to think about how we can bring this AI into the healthcare ecosystem. And it is constantly a training experience. And we realize that the future of AI in health is not just about one person building a model. It's about a data scientist, a clinician, often a pharmaceutical expert, a computer scientist that knows how to deploy and extract this information, and somebody that's sitting on the front lines with an actual patient. That's how AI will be developed in the future for healthcare, because it's going to take everyone to come together to think about all those different aspects to make it successful. So last but not least, as we close here, I want to talk about data and privacy, because this whole thing is about, can we get privacy? And I made it privacy and security because the reality is in healthcare today, one major gap that we have is privacy often is a all or nothing equation. We start with when you walk into the hospital, can we use your data for improving medical systems or for treating your care? And generally you say yes and sign your HIPAA agreements, and that data can get used a lot of different ways, where it's going and what they've actually consented to. Certainly it's all in the interest of the patient and improving healthcare, but you really don't know where your data is going. And so assuming you trust your institution that's managing your data, the question really becomes one of security, because when they start to work with that data in different ways, if they don't have the right security measures in place, your data is no longer private. I mentioned de-identification. Structuring data allows us to de-identify and anonymize data very quickly, which is a very powerful tool. However, de-identification and anonymization, many will say, is not enough. We can do it with Safe Harbor, which just removes data standards, but we need expert determination. We're finding even more, almost every data set needs that level to truly understand what are the unique identifiers that they aren't quite as obvious as name or address or diagnosis codes, but there's different trends in data that will expose somebody's personal identifiers, particularly if you link it with another data set. Even anonymized data sets today can be linked with other data sets, and some would submit that there's no such thing as de-identified data in the world. We're moving toward technology like differential privacy, which infuses noise at the beginning of data capture, and that allows it to truly be anonymized. But that requires a very large set of data to produce quality results. And so you really are seeing that only in a very small set of data, although it's evolving. You're seeing it, small use cases. You're seeing it in things like maps, and Apple uses it for their phone usage. But it's really not emerging at scale just yet in health data because we don't really have the right data capture points at the beginning. And so one of the things I'm most excited about, this slide shows, and I've got one more slide after this, this shows you the trend of how you think about data from a data owner's perspective. You might trust no one with your data and keep it on-prem so you can keep it fully private. You may know you need the models, and so you keep all your data in private on-prem, and you want to bring in models on the edge. So those models use cloud computing, but your data stays in your on-prem locations. Or you might start moving to the cloud. And so what we have now is the ability to bring that PHI in and keep it in your own cloud tenant. You can invite others in to work with it, but you keep the security. You aren't sending data files out of your system. You aren't sending it to other ecosystems, which essentially makes you lose control of that data. You have audit logs and control of everything in your own tenant, and a lot of our health ecosystem is really starting to move to that as they think about cloud. But then there's also my data in your cloud tenant. So if I'm working with a partner, independent software vendor, I might want to send some of my data into Boston University's environment so you can work with it. I trust you. But last but not least is the one that is, I think, most exciting is trusted execution environments, which is, I don't trust you with my data. You don't trust me with your model. Let's work together. And that's, we recently released what's called Azure Confidential Compute. There are a few other trusted execution environments that are out there. Google is very active, and it is a broad community that's working with this. This is not a single company. Tech is most powerful when we all work together. We all are working together around FHIR technology, and now we're working around trusted execution environments. And really think of this as an enclave. We used to have data at rest, secure in data store. And then we had data in transit across your network, and that's where FHIR comes in. Now what we've got is trusted execution environment, where the only two things that go into that environment are the data and the model. The keys to that environment are actually secure. So even if an administrator or key holder looked into that data environment, all they would see is session IDs. They don't see any of the data or the model. And the only thing that can come out of that environment is the output of the algorithm against that model. And this is it's a emerging technology. We're starting to see it at scale for especially financial services and healthcare, because these are the two environments where data has the highest bar and some of the highest urgency for trust and security. So if you haven't looked into trusted execution environments, this is kind of emerging tech. It's probably the one I think is most powerful for healthcare, and you're going to see it scale up rapidly in the next 2 years because of the need that we simply have with the scale of healthcare data and with the urgency around exchange that we know is so needed. So I close to ask you, AI, health data, and data privacy, how do they coexist in the cloud? It's not can they can. It really matters on how we're thinking about it, what types of scenarios we are lighting up, and where you, as the future of healthcare sciences, wants to take it. So we look forward to partnering with you. I'd love to talk to anybody that's interested in this technology and wants to work with our team. We do a lot of research, a lot of forward tech, and try and bring it to market. So I really appreciate the time today, and I think, Lisa, we might have a few minutes for questions. So I will close out and open the floor if anybody has questions today.
Thank you so much for your presentation. We really appreciate it. I know I learned a lot. We do have time, about 4 minutes or so, for questions. Please send them to me in the chat. To start us off, I would like to ask kind of a question. I know you already said that you are welcoming collaborations. Is there a sandbox to do some testing with the clinical data in Azure?
So it's a great question. We don't actually have clinical data in Azure. We don't look at patient data. We don't have access to patient data because Microsoft really operates as a platform company. And so we do, in research engagements, we will have a data exchange agreements with end customers and research institutions. And we go into a very specific engagement around that and say, this is what we hope to research out of that data, and this is what will come out of it. So we would always, if we work with your team on data sets, we would either include you and get you into the engagements on one of those arrangements, or we would partner up around a company that wants to work on it.
Okay, thank you. The next question is, the assumption in this talk seems to be that an organization such as a medical institution owns the data. How does the discussion change if the data is considered owned by the patient?
I'm so glad you asked that question, because that is actually not the assumption. The assumption is that the health organization is the manager for that data. We always believe at Microsoft, I personally almost always emphasize that it's your data as a patient. And so you give consent to someone to manage that for you, to use that data. One thing I do love about FHIR technology is that it actually levels the playing field for control to the patient. The same data set can be used to share patient data to the actual patient. That is why a lot of the US regulatory institutions like Center for Medicare and Medicaid is embracing it, because it actually reduces the cost of exchange and the duplicate store. It actually will lead to reduction in medical procedures, because I don't have to go to one hospital and say, I just had a blood test last week at this hospital, and you can go get the data. And they say, actually, we don't talk to that hospital. I have to go get that blood test again. And redo the same procedure, same cost, et cetera. So there's a lot of power in that. But no, the assumption is that patients own their own data. This talk was more around what happens when they give consent and send it in to an organization or a device or the cloud.
Thank you. Okay, we have 1 more minute for questions. So are you, slash Microsoft, doing work specifically targeting health equity using the tools you described today? And are there potential partners for BU Boston Medical Center in this work?
Yes. Yeah, one of the big things I didn't emphasize too heavily, it was on one of my slides, is social influencers of health. I say social influencers, not determinants, because I think there is possibility to change, but we are doing a significant amount of work now that we have this ingest platform for real world data. How do you marry it up with some of those large data sets that are probably already in the cloud for pop health, for a lot of the socioeconomic factors? How do you bring those together and really start to analyze and develop models that can be predictive or identifiers of where somebody's socioeconomic environment is impacting their health? And I think that is probably one of the most exciting opportunities for us to really transform the way people are getting care and the way people are identified in the health system for improvement.
Thank you so much for your response and for your presentation. It was really dynamic and engaging. Thank you so much. And for the audience for their questions. I do want to just remind everybody that we are recording the entire symposium, and we will be posting it to the Harari Institute's YouTube channel. And at this point, I would like to turn it over to Dr. Borrelli, who will be introducing and moderating the next session. Thank you, Heather. I really appreciate your participation today.
Thank you, everyone. It's great to be here.
Thank you, Heather. Now I'd like to introduce our second presenter, Dr. Eric Heckler. He's a professor and interim associate dean of community partnerships in the Herbert Wertheim School of Public Health and Human Longevity Science in the University of California, San Diego. He's also director of the Center for Wireless and Population Health Systems within the Qualcomm Institute at UCSD. Dr. Heckler is a fantastic transdisciplinary researcher, educator, and practitioner who works at the intersection of public health, health psychology, design, and control systems engineering. He currently has several large NIH grants as principal investigator in the area of systems engineering and numerous grants as co-I and many, many publications. The title of his talk is Overcoming the Hope Evidence Gaps Within Digital Therapeutics. Dr. Heckler.
Thank you so much. And thank you all for being here. And Heather, thank you for a great talk. Particularly, a key area for this discussing digital therapeutics is the importance of thinking about real world data and real world evidence. And a lot of the platforms you were just articulating really help to build that capacity. And so building on that, though, what I'm going to extend this into a little bit more of a discussion of how do we build real world evidence in a thoughtful way, particularly to get the hope that we have for these digital tools to actually come into reality. So first, before I get started, I just want to acknowledge my many colleagues. Particularly, I want to give a specific shout out to my postdoc, Milam Kim, who has actually made 2 key figures in this talk, and then funders and whatnot. So I always like to start with where I'm ending, just to kind of give you a sense of where I'm going. So the takeaways for the talk for me is basically that if you look at the variety of evidence, there's a lot of hope evidence gaps that exist. And what do I mean by that? We have a hope that digital health tools can be useful to advance health. And I particularly think would want to add in this notion of reducing health disparities. But I think we have a fear that a lot of times they actually are propagating them. We have a hope that they have desired effects, like helping people change their physical activity or diet or sleep or other sorts of factors. But the results have been, often underwhelming in terms of the actual sustained impact and benefits. We have this hope that they can be used in the real world for real world impact, but oftentimes that they are used initially and then they quickly drop off. So there's low adherence to their use. We have this hope that digital health tools, because they're in our pockets or on our arms and wrists or otherwise, can be used to provide just the right support at the right time when someone needs it, when there's an opportunity for them to engage in the desired suggestions, and when they'll be receptive to support, what my colleagues and I phrase as a just-in-time state. But oftentimes, those sort of nudges and notifications become disruptive and people just shut them off. And we want things that are evidence-based, such that when we're implementing them in healthcare systems or otherwise, we can have confidence that what we're giving is actually useful. But oftentimes there's sort of a double-edged sword to this one. The groups that are really good at building things are not necessarily good at building evidence. And the people who are really good at building evidence are not necessarily that good at building tools. And so on both ways, we rarely actually get to a place of meaningful implementation. So that's what I mean by the hope evidence gaps. Now, what I'm trying to figure out is what do we do to handle that? So what should we do? And here's basically my take-home message. 1, let's help real people first. And what I mean by this is really focusing concretely on creating and optimizing digital therapeutics or DTXs in partnership with communities and those serving under-resourced communities. And what we need to be doing is, the phrase I like to use is decision-based evidence making, really thinking very carefully on what are the evidence we actually need to get something to work in this real world place. And I hope you're hearing me. I'm really having you focus in on this idea of working in context. Our job is to get better at predicting and adjusting in real world contexts. And then later, and this is the key distinction, we ask questions of what's called transportability, what we often call generalization. I'll unpack that quite a bit more. We ask questions of transportability when it's actually justifiable. And I think rarely is it justifiable, but we often conflate this in our science. So this is where we're going in this talk. And now I'll try to unpack that. So let me give you a hope evidence gap example. So this is the work of John Jakisik and others. This came out a few years ago. And in case you hadn't seen this, particularly I want to highlight the popular press response of this. So actually JAMA used this as their kind of tagline: use of a wearable device does not improve weight loss. So that's sort of the summary statement of this. And let me show you some of the different press releases that came out about this. So study, wearable technology may not help you lose weight. Or what we've suspected about Fitbits all along is true. Wearable exercise trackers don't make people any more active. A flurry of new studies find. And actually, even though it says a flurry of new studies, it was almost all about this one study. And then this one I think is really fun. Sorry, your fitness tracker is probably useless. Okay, so this is the conclusions that are being drawn from this study, but let's unpack what happened and really try to understand what can we learn about this, particularly from, I think of myself basically as a methods dork. How do we produce the evidence needed to actually help us to help more people? That's my core goal here. So I think a big thing to note is the difference between the concepts, what we're talking about, and then the actual operations, right? And so this is part of generalization. It's called construct validity for anyone that has had that kind of past training, right? So let's think about it. What is the operation that was actually tested? Well, it was this thing. It was called a body media armband, is what they actually tested in this trial. An few things important to note about this body media armband. One, before the trial was even published, it was discontinued. Why? Because it was not actually very successful as a commercial product. It was not used by a lot of people. A lot of people found it very burdensome. They're basically this armband that went on a person's arm to try to help them monitor their activity and whatnot. It was very good from the perspective of actually there was a logic. They used it because it was really good for tracking and whatnot. But from a overall, getting this to actually be useful in the real world, it wasn't. It was very burdensome, basically. And so the key thing to remember is, they're saying wearable device, but all of these are variations of wearable devices, right? So are we actually, in that RCT, did it test a wearable device? No, it tests the body media armband as one key element. Another key thing to think about when it comes to this is what exactly was studied, okay? And so the key hypothesis in this trial was the idea that body media armband would be a low burden self-monitoring tool. Okay, so first I just told you, the commercial evidence would suggest that wasn't actually the case. Their own data was also suggesting that wasn't the case. Basically, coming back to the hope evidence gaps, they had this hypothesis that this would be low burden, but the people who were randomized to this intervention, everyone got a weight loss trial, and there was basically variations on how they did self-monitoring. I'll come back to that. But the group that was randomized to this one, they quickly stopped using it because they found it annoying and burdensome. They found it to not actually fit into their life and their routine. And so basically all those things in terms of there was low adherence, it didn't actually produce the desired effects. It was meant to provide just-in-time support and feedback, and it wasn't very well implemented. All of these are kind of true with this digital device that they were testing, right? But more importantly, perhaps also to remember, what was this being compared to? So whenever we're running an RCT, the question is not, does it work? The question is, does it work compared to what? And the compared to what was really important in this trial. It was actually active self-monitoring. It was basically giving people what we know has worked countless times in the past. And so it was actually a very high bar to pass to do this. And so the trial functionally ran something, testing it against a really rigorous control condition using a technology that didn't actually live into its hypothesized mechanism of action, low burden self-monitoring. And so the question that comes back to me is well, then what did we actually learn from this? And let me be very clear. This made perfect sense when John and others actually developed this study. I actually think that they were following really good, rigorous protocols and whatnot. I don't actually blame them for what happened. What I think is an important question of how did our trials, how did our methods and evidence production actually get us to there? Okay, so I think there's actually a problem in how we produce evidence from academia, and it produces these types of gaps. But I also think this is true when it comes to how we're thinking about even industry, and I'll come back to that in a moment, right? But I just moving into this idea of, I want you to really think about, this talk is all about how we produce meaningful real world evidence, okay? Which is an essential concept when it comes to digital therapeutics, whether you look at the ideas from the Digital Therapeutics Alliance or at the FDA, which I'll come back to in a moment, right? But the general idea, and you can see I've been articulate this in more depth in these papers that I'm referencing below, particularly this BMC paper, why we need a small data paradigm. But one way you could conceptualize the way that the assumptions we're making on how we produce evidence is we start by trying to produce generalizable, and I'm specifically using the word transportable knowledge, because the idea of transportable knowledge is you're trying to take insights from one group and then transport it to someone else, right? That's usually what we're thinking of as our sort of prime directive with RCTs, right? So we run a trial, we say, okay, does this work? And we're trying to figure out what is that thing that works in general, okay? The idea then is that we disseminate that to clinics and communities, and then we help individuals, right? This is the idea of scaling up and scaling out, right? So arguably, the entire field of implementation science exists because this pathway maybe isn't working so well. Okay, so and I'll unpack that quite a bit more in a moment, but just sort of planting that seed, like just there might be some weird assumptions we're making is what I'm trying to invite you to think about. And to give you an analogy to that, you can almost imagine that this sort of logic is following a similar type of logic to trickle down economics, where this is what we're told should be happening, right? We kind of produce evidence and then it spreads and helps everyone. But if anyone has done work with, looked at the work of Russ Glasgow and others, or even just as we're talking through this, I think what's actually happening is oftentimes, particularly when it comes to exactly the talk discussing the social drivers of health, I also agree. I tend not to avoid the word determinants. I use drivers instead of influencers, but same idea. A lot of times it's those social drivers of health and those behavioral factors that are really making it hard. And so oftentimes we're producing evidence and resources among well-resourced places, and in so doing propagating inequities. And so a really good example of this is the FDA pre-certification program. So forget the evidence that academia is making, let's talk about the evidence that industry is making, right? And so in the pre-cert protocol, these are the key groups that were being built out. And again, I want to give a shout out to my student Milim. There it is. Okay, cool. That was the key slide I wanted to show you. I don't know why that flipped around. Sorry about that. The key thing, if you note, in terms of who's actually taking part in this sort of fast tracking evidence for having scale, Apple honestly probably did the best when it comes to race. But the short summary is when you actually dig into who's doing this, these trials are being run among, weird, white, highly educated, industrialized, wealthy people primarily. And so there's quite a bit of assumptions on basically what resources they have, what's their context like, whatnot, that is setting up the likelihood for us to actually have real gaps in actually being able to really help real people in real world contexts in line with the hope that we have. And so again, the question I want to pose to you all is, what if our approaches, both academic and industry, are actually producing this? And so, of course, we've always talked about this in terms of the notion of a digital divide. And again, I want to shout out to my student Milim for kind of articulating, I think, this nicely. So oftentimes when we talk about the digital divide, I think we often think about it maybe in terms of this notion of the adoption piece, or maybe even the health literacy piece, But it's really important to remember that particularly our job is thinking about digital production and the way that, when you're building initial technologies, if you're constantly building it, with a certain group in mind as a starting point, and they have a certain amount of resources, and we constantly start with them, it's very likely we're going to produce a digital production divide, where there's just some tools, there's going to be some people who just get more and more digital tools and resources for them, and therefore for propagating inequities. And then similarly, even if we're building these tools, again, if we're building stuff where we're always starting with the well-resourced first, you can think about this in terms of building a digital evidence generation divide, such that we're constantly studying things with either inappropriate studies or under-resourced groups. And then this can result in adoption problems and literacy, which is, I think, the more common framings around the digital divide. So in this talk, I'm going to really zoom in here, although I think honestly, there's lots of important conversations to be had on all of these levels, but I'm focusing here because this is my own knowledge and expertise, but also in part because I think this is the logical bridge that helps us to work through all of these other layers of digital divides, if you will. Okay, so if that's the sort of problem, let's now start diagnosing what's going on to help us to figure out a solution. And I want to contend with you all that I think a key part of our problem in health sciences is that we actually have a very underspecified concept of the word generalization and causation. I'll come back to both of those, but our core goal for us, I'm riffing off of Shadish, Cook, and Campbell, that our raison d'etre is all about a generalized causal inference. The issue is that I think we often don't think carefully about what that means. And in particular, even Shadish and Campbell, they had this framing of two different dimensions of generalization. One of them you can think about as space, and the other one is time. And the one that we often overemphasize in my mind, and we try to jump to too quickly, is the space dimension, trying to basically get something that is transportable to other people and contexts. And what I would like to contend is that what we actually need to do to work through what we're trying to understand is actually to focus much more on the time pathway of generalization. And why? It's because we are working through a great deal of complexity, and we need to actually take that into account when we're trying to actually understand and make progress on getting things to actually work in the real world to actually help real people. Okay, and so the key part here is saying there's complexity. So what do I mean by complexity? Just to kind of unpack this, and why are our current tools and evidence, particularly randomized controlled trials, maybe hiding it? Well, here's a concrete example. Again, this is a great trial run in, published in 1998, Bess Marcus and others. And Bess is a friend. Again, I'm not critiquing this work. It was great work at the time. But this makes it look like physical activity is a nice, clean, linear process of change when someone's in intervention, right? This is all what we hope to see. But the issue is we now have digital devices, and we can now see what are actual steps like and physical activity actually like. And this is more what they actually look like. Each one of these is a different person, and you can see the dots, just how many steps they took on any given day. And the lines are telling you basically when there was major shifts and they were doing it, right? And so this is just, and this was not cherry picked of just 6 people who had different patterns. The pattern is very much, there's a lot more noise than not going on in terms of understanding when people actually engage in physical activity or not. And of course, I think we know why on some level, right? I summarize it in this way of basically saying context matters, history and time matters, and people adapt to their context, and therefore people have differences, experiences differences. And this is mapped out by a variety of psychological theories, but I think Mel Hovell's one is a particularly nice one to illustrate this point. So if context matters, history, time matters, and people adapt to context, this suggests that just thinking causally, like why do people engage in a health behavior like physical activity? Well, from a basic causal notion, you actually need to take into account context, time, and individual differences in your work. But often when you're using just a pure randomized control trial, you're literally randomizing that out. I mean, think about what randomized trials do, particularly when you're randomizing between subjects. You're literally trying to erase history. That's functionally what it's doing, right? So you can figure out, oh, how does this intervention versus this intervention have an impact? You're erasing this. And so if we constantly erase something that's literally important causally to understand, we're going to be lost. And that is part of what I think is our fundamental problem. Okay. And so again, coming back to some basics, this is again from Schottish, Cook, and Campbell. They had this nice phrase that I'd like to invite for you all to think about: causal descriptive models versus causal explanatory models. So causal descriptive models. This is basically like flicking a light switch 1,000 times to see if a light turns on. Okay, right? So you want to basically say, okay, I'm going to flick this switch, and every time I flick the switch, does the light bulb turn on or not, right? This is great. This is really valuable. It helps you to know if there's an effect when you do something. Okay, and this is basically what randomized controlled trials give us. And just to be clear, there's a time and a place for that. That's totally cool. I'll come back to that later. The issue, though, is that it's telling us if, it's not telling us how. Okay, you get how through causal explanatory models. So just to continue with the electricity example, you need to know how energy is produced. Like it falls down water falls down a hill, turns a turbine, produces energy. Energy flows through a bunch of wires. When you close the switch, that electricity flows through the wire, gets into your light bulb. Your light bulb has a tungsten filament, and when electricity flows through that, it creates resistance, which produces light. Right? That's how the light turned on. Okay, what we have been mostly spending our science on is understanding these causal descriptive. And what I'm arguing for as a foundation is actually causal explanatory models and working their way out. Okay. Okay, so I basically said the world's complex. We need to be able to take into account context, history, and individual differences. And we can do that through causal explanatory models. Now, why am I saying this? Honestly, I'm building, and particularly knowing that there's computer scientists, I'm sure many of you know Judea Pearl, arguably the world expert in causal inference and causal thinking. If you haven't read his book, The Book of Why, just to really reinforce this, it basically, at the level 2 of causality in Pearl's formalism is this level 2 of doing. And those are causal descriptive models. They're helping us to know if an intervention works. But if we actually want something to work in the real world, and there's all the complexity that Heather was highlighting before, we actually need causal explanatory knowledge. We need counterfactual thinking. This is coming back to the idea of the time dimension. We need to be getting, in part, better at predicting and adjusting in context. And that can be our first focus, okay? So that's sort of like, okay, if that's what we need to do, then how do we move to that? Well, I think, and now trying to simplify this and make it more concrete and actionable for everyone, it basically, then this again was articulated in these papers in more depth, but we basically should be shifting from this type of logic to this logic. And this is where my first take-home point comes into play. Help people first. Basically, recognize that our core goal should be getting better at predicting and adjusting in real-world contexts. okay? And working and building our evidence with that very much in mind. And from this, I want you to note, there is a pathway to transportable knowledge, and I'll end this talk with actually how we would move towards getting transportable knowledge, basically how we work through these buckets. But I want to say that I think in my mind, most of our work should really be consciously saying, I am working here, I am place-based, I'm going to help these people. And part of how we should select who we help are those who are most underserved. And therefore, we can work structurally to actually improve and reduce health inequities. And in so doing, I think we would actually start having meaningful pathways, not just to help people immediately with our work, but also gain far greater understanding of how the social drivers of health, behavioral factors, and biological determinants, how they're co-interacting to produce change. And we're basically aligning the roles of clinics and practice, okay? So that's basically where we're going. Let me try to unpack a little bit more concretely, how would that work? We're getting more into the how. So the big why here is what I highlight to. Now we're getting to the second part of my take-home point, is this notion of decision-based evidence making to guide real-world impact. It's basically saying evidence-based thinking is great, but evidence-based thinking right now has been conflated to the idea of RCTs, and RCTs are just useful for one very small part of the questions we need to use evidence for. And so the question is, what are the many different decisions that we need to be making to try to get different tools to actually work in the real world? And this is what my colleague Pedja Kalashi and I kind of framed as agile science. I've never actually published this. This is just on our website. I've been meaning to actually write a paper again, sort of like highlighting this. But here's basically the big why that we're thinking about in terms of what are those big decisions we need to make. The first one we need to make decisions on, which we frame as creation, is we need to create a clear sense of what is success within a context. We frame that as a niche existing within a broader ecosystem. Notice here, this is where community-based participatory action, community-driven design, and this clear focus on partnership really comes into play. Basically, we need the moral compass of the people we're seeking to serve to say, this is what's going on. These are our assets and strengths. But here's also what we're desiring in the world. Help us bring that forth with data and evidence. Okay. Once you have a sense of success and real world constraints, you can then start engineering this, which is basically optimization, right? This is where we start actually meaningfully building solutions that reliably produce success in context. This is where we actually focus on predicting and adjusting. Okay. Coming back to that framing. And notice no transportability here yet. And once we get good at that, we can start asking the question, where else might this be useful? That is when you actually have a conscious question of transportability. And this is where we could start meaningfully building out evidence around, does these intervention components are they useful elsewhere? You can think about those as modules or otherwise. So this is where the reuse comes into play, okay? So the decision-based evidence making is we're trying to make decisions on what is success for whom, what are the constraints in the real world, how do we build solutions, how do we keep working until we get success here, which is much more of an engineering frame of mind than a science frame of mind. But then once we got something useful, we can then science the heck out of it to ask questions of transportability. Okay, so this is where we're going with this. And this is a map on another way of how you can think about this. I want you to see that basically this inner circle is the create phase. So it's this. This medium circle is the optimization, is this circle, right? Basically work on the solutions. And then the last one is the reuse. Okay, so notice the whole idea is what you were trying to do, or what is being developed is in the initial phase, it's really partnerships, success criteria, and constraints. And notice I'm very consciously bringing in sustainment from the get-go. This is why it's not just an academic or industry, just as Heather said, we all need to be working together. I'm trying to articulate a way where we could all work together. And we do that. So if this is what we're trying to create, we do that through formative work, community-based participatory action, qualitative methods, design, and proof of concept studies, which are super fun, but I don't have time to get into them much. And then once you have that, and you basically have constraints, you can start using stuff from multi-phase optimization strategy from Linda Collins and others, the notions of optimization trials, with the core notion, again, that it's decision-based evidence making. You're producing evidence to help make decisions on how to get better at predicting and adjusting in this context. And from that, you can start building out the tools and the elements of a DTX, whether that be MVPs to usable evidence, to intervention components, to adaptation algorithms, to systems maps and DAGs, directed acyclic graphs, to platforms in line with what Heather was just presenting. Okay, so if that's where we're going, let me try to make this a little concrete in the last few minutes with more of like, well, I'm going to particularly zoom in on this one, because this is kind of, I think, the logical bridge that we want to be thinking about here. So I want to give a big shout out to my friend and colleague, Susan Murphy. She's literally the MacArthur genius who developed this method, and I was just lucky enough to help her think through it. So a microanimization trial. It's basically a randomized control trial, but what you're doing is you're not randomizing between subjects, you're randomizing within subjects. And so it's hence why it's a sequential full factorial trial. It's sequential in that you're randomizing over time within people. And note it's a full factorial in that you can actually have multiple factors randomized simultaneously. Okay, and so what you do is you randomize each intervention component at each time that you might want to deliver an intervention. So for example, say you have an intervention to help someone walk more, and you could randomize potentially giving them support each morning. Or you can, what we did, we randomized sending a nudge people 5 times a day to nudge them to take a few more steps, like a 10-minute bout of walking, right? So we had these 5 decision points, and we randomly decided on any one of those 5 decision points if we sent that notification or not. And then we can have multiple components randomized at the same time. Again, the example I'm going to show you, the first MRT, as far as I know, was ever run that I was part of. We were studying not just that notification, but also this notion of implementation intentions. And they were run orthogonally so we can figure out what each one of them is doing. And with this, because we're randomizing within subjects, you can often randomize hundreds, if not thousands of times, even with just individuals. And so you can basically get a very well-powered trial with a very small, not very small, but a relatively small number of people. So you can learn a lot with a little. So let me give you an example of this. This is the original Heart Steps trial. As I said, we had a little context notifications asking people things like this. How about going for a walk, basically, And so what we did is we took into account a variety of factors when we sent this. So we took into account the time of day to frame what message would be written, if it was a weekend or weekday, location, weather. We also sent 2 different types of notifications, to walk or to interrupt sitting. And we ran this just over a 6-week trial with just, I think, 40 people or so. And that was actually well powered, just to be clear. So what can we learn with a trial like this? Well, you can learn a lot. So first, we can learn the main effects. You can see the results of the trial that's been published. Basically, what we learned from this trial was that this intervention in general did work, but more importantly, when and where does it work was a very important question. So probably not surprising, and in line with sort of like our hype evidence gap issue, or the hope evidence gap. We did find, this is the time varying effects, we found that it was really useful in the beginning, but it started to basically drop off. So it showed the very clear low adherence problem that was coming into effect. So we could get a clear causal evidence on when this would work and start to stop working. We could also study things like time varying moderation. And this is one of those really interesting things. What we found was if we sent fewer than 2 notifications on any given day, they actually still worked even at the end. And so it was really, when you start looking into the subtlety of this, we started getting evidence suggesting, okay, this is actually a useful tool, but it needs to be sent during just-in-time states in line with our theory. And so we built out follow-up trials and whatnot, where we're actually trying to take this evidence and take it into account. But I hope you can see from this, with a relatively small trial, these MRTs can help you actually fill a variety of things. You can literally, other people like Billy Nahum Shani, has done this to study issues of adherence. You can study it to basically understand just-in-time states. You can really use it to iteratively improve on getting these tools to be used in real-world context, right? So it's a really efficient study designed to help us learn an awful lot with very little data, basically. You just have to be kind of clever about it. So that's sort of this, and there's many other examples. There's a factorial trials, there's smart trials, there's stuff I do a lot more in control systems, which is around using system identification experiments. And of course, there's data-driven optimization and whatnot. But I want to come back to give you a second example of this, particularly coming back to this idea of what do I mean by partner with local groups? So a group I'm very actively involved with is Family Health Centers now of San Diego, the largest federally qualified health service in the country, or not in the country, sorry, in San Diego County. And they're specifically focused on supporting underserved and under-resourced populations and groups. And so we've been engaging in a process together that basically fits with this general process of engagement. We've been guided by Greg Ahrens, although it's kind of an adaptation of his work, the EPIS framework, explore, prepare, implement, sustain. And what we've been working on is trying to understand, again, create the phase, what is success for whom? We're really landing on this notion of hypertension as a core problem area in the group. And what could we prepare to kind of fix this that actually fit into the real world context? And a key question for them was basically, when and where is it most helpful to actually provide telehealth coaching or not? And when and where is it most helpful to provide medication adherence reminders and support or not? And so this is a 2x2 micro-randomization trial that we're actually, we haven't been funded yet to do this, but we're seeking funding actually right now as part of this. But to just kind of give you an example of the ways that you could imagine embedding this in real world contexts to produce real world evidence about digital therapeutics. And I could give you more, but I don't have, I'm basically out of time functionally for this. So the very last thing I promised you on was around the question of transportability, coming back to that. Actually, key question, how could this be funded? In case anyone's wondering, I think there's actually lots of interesting ways of actually funding this through SBIRs. I think there's increasingly funding opportunities. If you think about this as basically a more rigorous version of quality improvements, there's pathways. And then also you can do advocacy. This is something I've been actively involved in, trying to argue for more agile funding models from philanthropy and government. And I think all of those are important. And so this is sort of setting up the space. The last thing I want to briefly hit on is the notion of transportability and reuse. What would this look like? Well, so again, coming back to it, this is the final phase of this little model and development, right? And so this is no doubt, RCTs are totally cool as long as it's the question that you actually are asking. That's all I'm saying. It's decision-based evidence making. If your decision is reuse, great, do it, right? And so you can imagine, I'm just pulling on this example of, but notice what I said before was this idea of having a causal explanatory model. And so socioeconomic status is one, I could have picked many, right? But imagine basically you have a digital version of the diabetes prevention program, say like Omada Health, right? What are the different ways in which causally socioeconomic status might have an impact on the evidence that you produce? And I would argue that there's actually three that you might want to be taking into account. And this is, again, building on kind of logic from like Russ Glasgow in particular, right? But one, first, SES will impact the percent of individuals who enroll among those contacted for the study. So in particular, individuals with low, medium versus high SES will have significantly different enrollments among those contacted in each group. So this is like before you even build the evidence, right? This is the starting point of re-aim. Like, who did you try to reach and who did you turn down? My hunch is there would probably be systematic biases there. If you have a DAG, if you have a causal explanatory model, it's basically the same thing. If you have a causal explanatory model, you actually would take that into account, and then you need to actually build evidence to show either that it actually is truly transportable or not, right? So a second one, individuals with low, medium versus high SES will be significantly impacted by DPP adherence. So great, you get them in the trial, and those perhaps who are under-resourced will be harder for them to adhere to all the principles of the DPP, the digital tool. And then last, I actually didn't mean to have Omada there. So just imagine a digital device company will result in significantly weight loss. I'm not trying to pick on Omada. I think they're great, actually. This is more of just building evidence. Truly, I am a big fan of Omada and what they've been doing. So, but like you can imagine running a trial like this, where you're actually consciously building and you have enough analyses to actually do the subgroup analysis. You don't just take the aggregate result and say this is transportable. You actually build the evidence to prove that it's transportable in something that you know causally might be impacting differential response. You see it? And so that to me is sort of the logic on how we actually build a rigorous transportability. And of course we could build more. So my take home message is hope evidence gaps exist. What do? Help real people use appropriate methods by doing decision-based evidence makings. And then when we run our RCTs to actually study it, we consciously do it when we need evidence of transportability, and we actually study that. Thank you very much.
Great, thank you, Eric. That was fantastic talk, very forward thinking, and has us really, you're really thinking out of the box here. So I appreciate that. We have several questions. I have one of my own, but I'll ask the groups first. So one person asked, research interventions are based on the principle of clinical equipoise, that you really don't know if an intervention will be effective for a participant, and that's why you do the trial. How do you balance equipoise with the principle of help people first?
Yeah, that's a fantastic question. And I think it ultimately does come down to when you actually have so one way I think about agile science, that sort of frame, like to me, the very high level point is basically identify the biggest assumption you're making, figure out the most efficient way possible to test it, and then repeat, use a different method. So why am I starting there with the answer to that question around equipoise? Equipoise is very important, right? In my mind, a key thing you want to think about when you're trying to figure out what your assumptions are making is, do you truly have a question? Right? For example, you could have high confidence that something's going to work. If you have really high confidence something's going to work, go do it, right? Basically make that become something that's foundational for you, right? But also if you have no clue if it's going to work, that might be time for you to actually do more basic science work and other sorts of work. And I'm not negating that that's not true. Actually, I'm a big fan of also this work on science and behavior change. And I think there are a lot of work that we can do to really sort of think through mechanisms and processes of change and whatnot. So this is just one perspective on if we're actually building tools, right? So to me, the sweet spot on when we ask this question is truly when you have equipoise, when you basically like, you know what, I'm really not sure which one of these versions would actually be most helpful. And that should, and so, but my hunch is coming back to helping people first. How do I balance those two challenges, right? Ultimately, I think that there's a chance that either one of these could be useful, right? If you don't really think that there is a possibility that both of these could be impactful, you probably shouldn't be running your trial. But more importantly, and coming back to this sort of usable evidence or decision-based evidence-making frame for this, when you're running these trials, particularly when you start thinking this way of like you're trying to actually build evidence that helps you make decisions in real world context, one of the follow-up questions, you don't have to be bound to the question of which one's better. You can ask a whole bunch of other questions. For example, which one should I start with? Which one of these is most appropriate for different subpopulations? And so you can imagine building this much more as a tool for building stepped care models and whatnot. And so in my mind, that's usually more of where I'm thinking, right? Where usually we have some variant of standard of care and we want to ask the question of, can we do better than that standard of care? We're always trying to build up our evidence base and accumulating knowledge base in the real world context, starting with what folks are actually doing. And so you can argue that that already is a starting point on saying, we think this will already help. And we're trying to see if we can help them any better, but we're not going to change standard of care unless we actually have evidence to actually suggest that it's worth it, basically. Or we need evidence to help us to do the stepped care and the sort of treatment matching that we would need for it. Again, producing the right evidence to actually help get the better at predicting and adjusting in real world contexts.
Great, thank you. The next question is, how much do you think these micro-randomized trials will lead to commonalities in evidence for intervention methods versus lead to evidence showing that different people will respond to different types of interventions, that is, precision interventions?
Yeah, I mean, my own experience from my own trials is that it's going to be more of the latter, but I would reframe that a little bit. Coming back to, that's why that causal explanatory model is so key. You know, right now, when in the methods that we've been using, particularly between subject randomization, again, it randomizes out differences in context, history, and individual differences. And so, and of course, we can build that back in by building moderation analyses and stuff, but it's a relatively clunky understanding causally of what's going on. Right. So when you actually start getting the time series data that we can get from wearables and digital devices and other sorts of things, we can actually start to understand and unpack not just the question of, oh, well, there's different people. This is coming back to the notion of a just-in-time state. There's different times and places when different people need different things. You know, so from a different trial and stuff that I was doing more on system identification, we basically ran and developed individual computational models for each person taking part in the trial. And I didn't talk about that trial at all today, but just as an example of that, when we ran the nomothetic, so the on average, the aggregate data analyses that you're used to using, we found basically that weekend was the key tailoring variable that we should pay attention to. When we ran it idiographically, meaning we ran it for each person, what we found is that that was the appropriate answer for 25% of the sample. But by implication, 75% of the time, we actually had the wrong tailoring variable or sets of tailoring variables that would matter for each person, suggesting that it's much more of a state space formalism. And this is where I think some more of like the work on state modeling and state spaces, which can be articulated within causal explanatory models and other computational models, allows you to actually work through that in more depth.
Okay, thanks. How do small trials using these types of technologies in a small sample in a specific context or location translate to larger clinical trials?
Right. I think you just missed the core message of my talk if you asked that question, just to be completely frank. Then just to come back to it, what I'm trying to say is there are two pathways to generalization. Okay, one pathway, and I'm glad but just to be clear, I'm sorry, that was maybe a little crass of a way to respond to that. I think that's a very important question, and I'm glad you asked because I did not communicate well, is what that question suggests to me. So thank you for allowing me to kind of reiterate this key point. You're exactly right. The normal question that we like to think about is that question of like, how does this translate? How do we get this to scale, right? That's sort of our bias. And the way that we think about that is we think that we get that by using the assumptions of frequentist statistics. And we have this hope and prayer that the frequency statistics will generalize. But more often than not, again, going into lots of work from dissemination and implementation science and other areas, more often than not, these things are not actually being translated. So there seems to be a misunderstanding on how we actually get something to meaningfully scale, is what I was trying to get at within this. And so that's the problem. Now the solution, well, how do we get there? We get there by better understanding how and why things happen in real world context. And we can do that because we have digital devices increasingly that allows us to measure things at the right time scale and within context, such that we don't have to ignore context, history, and individual differences. And the pathway, therefore, to generalization first is through the time pathway of generalization, which happens by getting better at predicting and adjusting in context. It's just like knowing, coming back to the light bulb example, it's like knowing when the light doesn't turn on, how it's all working, so you can actually diagnose what the problem is in that context right there. That causal explanatory model, that map of how things work, is highly generalizable. And even coming back to Shadish, Cook, and Campbell as an example, they said this was the best way to get towards causal inference, is actually having causal explanatory, not causal descriptive models. But we keep building most of our evidence on causal descriptive models. That's what the frequentist statistics and RCTs give us. And so I'm basically inviting us all, if we actually want to get us towards meaningful generalization, let's start first with understanding how and why things work. And we can do that because we now have digital tools that actually helps us to actually study how things work in real world contexts. And as you do that, it has a completely interesting complementary benefit of aligning the interests of researchers and aligning the research of practitioners and individuals themselves, because we can align it to the same success criteria. We are trying to get better at predicting and adjusting towards producing the real world success that everybody wants. And so it also quickly reduces our implementation challenges, right? And as we get better and better at that, so right, I'm just building evidence there. What's generalizing? One is we're learning how and why things happen in the real world. And so those causal explanatory models, which could be formulated as computational models or otherwise, could start to be used to guide when and where things might work or not work elsewhere. So that's one pathway to generalization. But then another pathway is, as you're getting better at building tools that actually work in the real world, you can start to then meaningfully ask questions of transportability, where you can actually consciously say, I think this will work in this context with this group and not in this context in this group. And let's actually gather the evidence to show that, so that you're actually experimentally testing issues of transportability and therefore scaling up and whatnot.
And then my question is, just in the last minute or so, these are a lot of innovative ideas that turn traditional design thinking on its head. And so what challenges have you had or criticisms with these ideas? For any challenges, either scientifically, conceptually, or from NIH funders or?
Yeah, honestly, my experience is when I usually unpack this with folks, the general response is, now that I get it, I think you're right, but that won't be fun. That won't go through study section.
Right.
And so that means it's not a scientific problem, it's a political one. We basically, in my mind, we have, and if you read like Thomas Kuhn, The Structure of Scientific Revolutions, to me, that's the problem, right? When do scientific revolutions happen? According to Kuhn, it's when the old guard dies. I actually don't want anyone to die. I would like everyone to actually be able to think thoughtfully together, but that does require us to actually do some degree of recalibration and perhaps unlearning some of our, gold standard practices. And maybe just, if I may, just to end on that, right? Has anyone ever thought about the term gold standard for a moment? Think about it for a moment. Where did it come from? It came from money, right? Literally, we had our money bound to the gold standard. You should read a book, I think it was Jacob Goldstein, Money, the story of an invented thing. The long story short, the notion of gold standard was also problematic for money. It actually made it harder for us to actually have money, because what is money? It actually is a representation of trust between people. Okay. Similarly, what is our gold standard when it comes to like scientific trustworthy scientific information? Consensus. It is trying to build like where we're constantly arguing with each other such that we actually land on something that is meaningful and worthy of trust. The notions that we have around there is a single gold standard is actually highly problematic from the perspective of doing data. And so coming back to it, my experience is whenever I bring these up, like I always invite, if you think that I understand something inappropriately from a philosophy of science, methodologically, from a goal on what we're trying to produce in our science, challenge me. I'm rarely challenged at that. The only thing I'm challenged on is, well, that's not politically viable, which therefore means we have chosen learned helplessness as our pathway to try to help each other. And I don't think that's a very good choice, particularly because we have enough resources to actually try to help people meaningfully with our science. And I think it's our moral and ethical obligation to do so.
Thank you. Thanks for answering so comprehensively and for the book recommendations too. So really appreciate
many books if you ever want those, but
yeah, so we really appreciate all of your time. So I just wanted to do a quick reminder that to remind everybody that the video from today's session is going to be posted on Harari Institute's YouTube channel. So now we want to begin our breakout sessions. Okay, welcome back, everyone. Lisa and I would like to welcome you back, and thank you for your participation today. We have our third presenter. I'd like to welcome Professor Simon Fedor from MIT Media Lab, where he's a research scientist, and he leads several studies using effective computing and body-worn devices to study well-being and mental health. He has extensive experience in research related to wearable technologies and embedded systems, both in industry and academia. He's published a book chapter, and over 50 papers and conferences. And the title of his talk is Monitoring Health and Wellbeing Using Longitudinal Passive Data. Professor Fedor. Oh, you're on mute.
Yes, thank you very much for the introduction. And so
That's better.
Can you hear me now? Yes.
Yes.
Okay. So let me share the screen and okay, can you see my slides? Yes, okay. So thank you so much for the introduction and then for giving me the opportunity to speak about some of the recent technologies and results that we hope in the future will help many people to improve their health or well-being. So in terms of the scope of the talk, I will provide first some context why we are working on new monitoring of mental health and as well well-being. Then I will present two studies which cover actually two different populations. So one is one where we work with depressed patients and we were trying to find out the new ways how we can assess their depression. And the second study when we work with a healthy population and we were studying office employees' well-being. And finally, I will draw some conclusions about where we think this type of research will go in the future, what our research show as well. So let's start maybe with a definition. What is really mental health disorder? So, and according to American Psychiatric Association, it's a health condition involving changes in emotion, thinking, or behavior that are associated with distress or problems functioning in social, work, or family activities. And when we looked closer at these aspects, actually current technology enables monitoring of some of these features. So for example, emotions, behaviors, we can use different approaches. We can collect surveys, but as well, to a certain extent, even passive sensors give us indication of emotions or arousal or behaviors. So in addition, using this passive technology, we can monitor these aspects continuously, which is a huge benefit. If we look at the statistics from WHO, mental disorders are the largest cause of disability worldwide. And they represent more than 25% of our causes, and even more than substance abuse, and even more the causes like cardiovascular diseases of cancer. So this becomes actually a really huge problem. And now even when we look at the trends, we can see in the last 10 or 15 years, we can see an increased prevalence of depression, in particular among young population and below 30 years old. We can see that in universities, we at MIT, and I suppose it's similar at the BU and other schools. It has been widely published, and as well even younger populations like school or middle schoolers. And in recent years, due to the COVID-19 pandemic, the trends was even more exacerbated. Many lifestyle changes, like, for example, social isolation, more sedentary lifestyle, and as well increased stress, have contributed to the aggregation of the symptoms. And even in the case, if we look at it's more pronounced, the change was more pronounced in the younger population, but it actually spans across different ages groups. And in the next 10 or so years, we see another trend, which is an increased availability of passive data sources. What I mean by passive is the sensors or wearable devices which collect data about the user or his environment without and do not require any active input from the participant. So it could be either like a wristband sensors, but it could be as well the sensors that we have integrated in the mobile phone. And these sensors enable monitoring of certain features related to depression, like, for example, activity, sleep, or arousal. And as they become widely available, we think that the health services based on the data collected from these devices can become commonly available as well. Where could these sensors actually play a role in the clinical practice? Well, it's actually a huge subject, and I think it'll be one single talk based on that subject delivered. But when we just give a quick overview, so first, they can improve diagnosis, as the sensor can provide a continuous and objective measure of depression symptoms. So we can imagine that in the future, clinician may get some sort of overview of how the patient was doing in between the visits, based, for example, how was the pattern of the sleep, how was the pattern of activities, of social communication, and so on. In addition, they can help us as well to predict risk of certain disease. So in the physical health, we use measures called biomarkers to, for example, predict or risk of certain, for example, cardiovascular or cancer. In mental health, it doesn't exist at all. We don't have a single biomarker used in clinical practice. So we hope that the early detection or projection of the disease trajectory can help us actually even to use in the future, can be used in the future in clinical practice. And finally, as well, in terms of the treatment, these devices can enable personalized treatment or just-in-time intervention. So now, if we step back and we look at the context of our studies we have done, most of us experience difficult or stressful situations in our life. However, some people unfortunately end up on this bottom line of the graph, and they are more vulnerable, whereas the others become more resilient. The purpose of all our work actually in this domain is to prevent this red line trajectory. We hope that the technology we develop can help us to be on a more preventive side rather than, respond to the already existing disease. So in terms of the studies I'm going to talk about two projects. One was called Grand Challenge Study, where when we work with the depressed population, and we were looking at how we can better diagnose people with depression. And second is a call center study, where I was working with a healthy population. And in this case, we are looking into monitoring using passive technology, well-being of the call center workers. So let's start with the Grand Challenge study. Our overall goal is to use passive sensors data and only passive sensors data combined with the AI models to estimate depression level as predicted by a clinician. So what we did in the study, we enrolled depressed participants, and during a 2-month period, they were wearing wristbands on their both wrists, and we also installed an app on their phone to collect passive measures. The participants were also assessed for depression by a clinician every other week. And what we have done, we built AI models to estimate depression score from the passive measures collected 1 week prior to each assessment date. Why do we think it's important to do this type of a study? Well, current methods or traditional methods, which are used currently in practice to assess depression, have been developed over 50 years ago. So the way the process works now is a person is invited for a clinical interview and is asked a list of standard questions. We can use a different standardized questionnaires. One of them could be, for example, Hamilton Depression Rating Scale. And for each answer, for each question, the clinician assigns a score depending on the answer of the patient. And then the clinician calculates the total score and provides the diagnosis. So obviously this method has certain disadvantages. Well, first of all, it's very subjective. So depending on how the person communicates his or her experience, mostly in the last month or so. Secondly, how the clinician interprets the results. The person can end up at a different level of the scale. Secondly, the method is actually symptom-based. So the symptoms have to be already present in order to be able to say, okay, the person has a depression, whereas there might be as well some other symptoms which are, for example, physiological, which as well might be very important, but the method doesn't really take them into account. And finally, it requires accurate communication, whereas nowadays we even diagnose children who haven't developed language skills and they are depressed. So we cannot really we cannot really diagnose them using this approach. So we hope that the new technology, which is based on the passive measures, can enable more objective and pre-symptomatic assessment of depression. In terms of the protocol, what we have done, so as I mentioned earlier, people were enrolled for 2 months, so over 8 weeks time. They were wearing continuously 2 wristband sensors. We as well installed an app on their phone. Then they were assessed every other week for depression using a certain standardized questionnaires like Hamilton Depression, QIDS, PHQ-9, and so on. We assessed them daily for mood, sleep, and behavior using mobile surveys. And as well, we collect their voice characteristics. I will tell a little bit more why we collected voice characteristics later on. And finally, as well, we assessed their sleep features using an in-home EEG device. We enrolled 36 participants, over which 32 were with depression. And the monitoring phase took about 2 years for us. Okay, so what kind of specifically more in terms of the data or passive measures we collected? So we used this in-home sleep monitor using 2 EEG channels. It gives us sleep phases pattern. In terms of physiological measures, we use 2 wristband sensors, which provides us measures of electrodermal activity, heart rate, temperature, and acceleration. We monitor as well phone usage patterns. So information like screen on off time, some meta information about the phone calls or SMSs, but no content information. As well, we collected location data, how people are moving throughout the day using GPS. Next modality was voice characteristics. So because there are studies which show that people's voice changes in depression, we ask the participants to record a diary once a week, which we later on analyze to extract voice features. And finally, we collect the surveys. I mentioned them about the sleep, general health and context, but we did not use the surveys into our models because they require active input from the participants. How was our adherence? This is one of the questions we often get is, you ask people who are depressed to wear the sensors, did you actually get a lot of data? And it wasn't really too bad. So in terms of, for example, wearable sensors, we expected people to wear them for 56 days. However, there were times when people had to charge them, they forgot to put the sensors, they had to upload the data daily. So overall, our adherence was about 75 or 82%, depending on which hand we are considering. Then in terms of the continuous recording, we had about 83% adherence overall. From the diaries, it was the lowest one, so it was 71%. And finally, the highest adherence we had from the night and sleep home devices, but they were only worn for 12 nights in maximum. How did we process all this passive measurements? So we aggregated them actually over 6 hour and as well 24-hour periods. So we divided 24 period into 4 6-hour intervals, night, morning, afternoon, and evening. And we aggregated specific modalities. So like if we take, for example, heart rate, we process average pulse, or SDNN for heart rate variability. For the skin conductance or ectodermal activity, we process skin conductance level or skin conductance response. And we aggregated this instantaneous measures over 6-hour times using mean, median, and standard deviation. From the phone, the specific features we had, it was number of calls, SMSs, the length of the call. We as well analyzed or collected phone display on off, app usage, what type of app people were using. I talked already about the wearable, which is the E4 sensors here. We matched location with the weather data to take into account as well the seasoning depression. We analyzed motion based on the acceleration from the E4 sensor. We took the sleep data as well, again, based on actigraphy. And finally, the HRV, heart rate variability, and EGA as well. And overall, when we did this process, we had over 800 features. And we obviously had we applied some methods to reduce the dimensionality of this data, which I will speak a little bit more later on. So this is our overall machine learning process for analyzing of this data. Maybe what is really as a important message is here, we use ensemble method, AdaBoost, to combine different machine learning approaches. And what we've done, we just run cross-validation to estimate the accuracy of our method using mean absolute error. So one of the results here is shown on this graph. So on the y-axis, we have passive data predicted. So basically predicted HDRS score. HDRS stands for Hamilton Depression Rating Scale from the passive data. And the x-axis, we have the actual HDRS score provided by a clinician. Overall, we get a correlation about 0.83. It was statistically significant. One of the disadvantages of the study, and this will be shown later on in the results, so I will point it out now, you can see the color actually corresponds to each user data, and they are somehow clustered, the points. So which means people did not really respond to the treatment as much as we wanted. And whereas our goal is actually to have patients for whom the depression varied significantly so that we can build better models. And the consequences of this, the type population we enrolled, was actually visible later on in the results. I will tell you and how, but as well, we now have a follow-up study funded by NIH where we enroll patients. We try to enroll populations who have been recently diagnosed with depression, whereas here we had the people who were chronically depressed. So for this type of population, very often depression doesn't change significantly, even if they change the treatment. We look as well for the most relevant features to the depression. So we used one of the existing algorithms called Boruta, and we identified 39 features which were mostly relevant to the clinical score. And they span different modalities, but they're coming from both from the phone and the wearable. Mostly they are either related to phone usage patterns, as well location changes, like especially variability of the location. They are as well based on the electrodermal activity score and as well heart rate variability. So this was actually pleasing results to us because we were one of the biggest effort we had in our studies to enroll people and ask them to wear the devices. Many studies which exist now in the literature, they are mostly based on the phone-based data. In addition, we try to analyze accuracy of our model in different scenarios. So for those who are working in the machine learning area, the usual approach is where we randomly split train and test data. And that's what we use for our tests. So this is this is a very standard approach to test accuracy of the method. However, we use the other two scenarios where we call the first one, which is time split, where we train models on the first 3 weeks or 4 weeks of data and test it on the last 2 weeks. So it might be like a scenario where we have already a patient, we build a model for the specific patient, and we try to estimate his or her depression in the future. So like predict existing patient. However, there might be another scenario where we split training and test based on the user. So if we imagine a scenario where we ask a person to wear devices, but the model, his or her data is not or yet included in the model, and we try to predict his or her depression without training any model based on his or her data. So we call this user split scenario. And when we compare these using standard machine learning methods like linear regression, decision tree, KNN, or so forth, the mean absolute error for our methods is about 5. So if we imagine that in the context of our study, it was Hamilton Depression Rating Scale, which goes from 0 to 55. If you are 55, you are very severely depressed. We get about 10% mean absolute error with the standard or traditional machine learning methods. However, when we test it versus some baseline models, like for example, a model which we call a personal screen, which is the model, very simple one, where we assume that the screen value is the value of the depression of the patient throughout the whole study, which is very basic one, right? So this type of model outperformed the traditional machine learning approaches. So, and one of the reasons why is because, as I mentioned earlier, the depression score value of the patients didn't move at all because they were already chronically depressed. So we were looking for other approaches, more personalized. And we applied basically a method which is called mixed effect random forest, which is a combination of linear mixed effect modeling and which is coming from the statistical domain, and the random forest, which is more from the machine learning domain. And we found that using this personalized approach, we can outperform these even basic models in the time split scenario. However, in the context of the user split scenario, it's not the case. And the reason why is because in the user split scenario, we do not have a user's data to train the model, right? So this is the scenario where we train the model without the user data. So we cannot really personalize or adapt the model to the individual. So we are now, this is an ongoing research in our group, is how we can even outperform these other approaches in the context of user split scenario. What we have done as well, we built a visualization platform and to facilitate conversation around the data between the clinician and the patient. So the clinician could show the data from the users during the clinical visits, and so we updated it on a regular basis while the patient were enrolled in the study. They could see their own, for example, motion data, they could see their sleep data. We could as well see aggregation of the data over specific groups, like those who had a recurrent depression versus those who had the first episode of depression. We were looking, for example, how the motion changes for these participants. And it was very actually successful. We didn't originally plan it. However, the clinician told us this is very helpful for them because now they can as well compare this data, this objective data, with the interview outcome. So the second, I'm moving now to the second study where we, as I mentioned, is the study where we looked into the well-being of the clinical office, of the office workers, mainly the people working in the call center. What we did in the study, we are looking for the association between their stress, their well-being, and as well their performance at work. what we did, we enrolled 180 employees and we monitored them for 30 days using different type of passive monitoring methods. Like, for example, wearable sensors to measure especially their physiological signal or sleep patterns. We looked at their phone usage patterns, location, how they, commute, how they move throughout the day as well. We collected some surveys, mainly for the context information, and finally, we as well collected some well-being self-reports. We actually looked into a number of parameters, but in terms of the surveys we collected, there was a pre-study surveys, post-study surveys, and during the day as well, there were some daily questionnaires asked to the participants, namely about their, for example, general health, sleep, and as well, for example, their mood. One interesting result we found in this study is related to sleep regularity index, and it has been actually replicated in other populations now. So this might be as well interesting for people who are working on passive monitoring of data. So as you can see here, we have graphs of two different people who, one of them on the left we can call regular sleeper, the person on the right we can call irregular sleeper, and how we can identify this? Well, the x-axis represents the time of the day, and we have data from 2 consecutive days, from midnight to midnight, the first one, and the second from midnight to midnight. And the black line represents the time when the person is asleep. So if we look on the regular sleeper, the person is sleeping pretty much around the same time from night to night. Whereas the irregular sleeper, as you can see that these black lines are pretty much scattered throughout the night or even day. And we can quantify it using a metric called sleep regularity index, which is from 0 to 1. And whenever a person is, we basically divide 24 hours into shorter intervals. And whenever a person is doing the same activity at exactly the same time, we increment the metric. And whenever a person is doing different activity in terms of sleep or awake, we decrement the metric. And it's between 0 and 1. And what we have found is that the people who are regular sleepers, usually when they responded in the morning surveys, they were, in general, they're in a much better mood, they're more energetic, their concentration was better, and so forth. And it has been actually replicated as well with the student population. So this is one of the metrics we now use in our other studies to monitor, for example, well-being. In terms of the conclusions of this work, so first of all, we found that we think that the availability of wearable devices enables passive monitoring of well-being and mental health, and this is going to be even more and more, visible, and there'll be more and more studies coming now because these devices, they become more sophisticated. They are much more user-friendly. In the past, it was much more difficult to find a device which provides raw data, and it's easy to use throughout the months and so also. Secondly, because we compile or process what we found in our analysis of the most relevant features, both the physiology, location, phone activity are actually relevant to the depression symptoms. And all of these measures are passive. And finally, because we still think there's a need to improve the AI models, we need to build or develop new personalized methods to accurately assess mental health, because most of the illnesses, especially mental health related diseases, are heterogeneous and complex problems, and they are very individual. So the generally machine learning methods are not sufficient. It has to be personalized. If anybody is interested in more details, here's a list of some of the publications. We have as well a project website called sensecode.media.mit.edu, and I would like to thank all of my collaborators without whom this work wouldn't be possible. And thank you so much for your attention, and I'm looking for your questions. Thank you.
Thank you. That was really compelling and cutting edge. And I know many of us who do intervention research are really looking for passive measures of depression. So it's really going to help us. So I appreciate that. So I'm encouraging everybody to type their questions into the chat to me. I don't see anything so far. Lisa, did you get anything? Or? No, okay. Well, I guess I will take the prerogative and ask the first question. So, in your research, has some of the biomarkers, well, the wristband or the phone calls, voice characteristics, have some been better predictors than others, and for whom? So, are there moderators of those effects?
That's a very good question. Yes, and what we have done, we have looked into the generic comparison, especially in the depressed population. So this is one question, and the ones which we found most relevant are the ones which I listed in the presentation. And having said that, I think it's a very good question because, for example, one of the metric of which we use now is called topography, basically. And what it really is we can now measure how people, in terms of the length of the sleep and certain other parameters like sleep wake time or onset sleep time, using only the screen on off time from the phone. And however, this metric will be only accurate for certain type of population. Mostly, I'd say people who are let's say below 50 or so, and at least there are already studies which are showing that we cannot use and assume that a specific metric could be applied across different populations. So in terms of we haven't really in details analyzed yet. Okay, could we use I don't know, EDA, for example, only for a certain gender or a certain age group? But definitely there is a potential to look into that, especially with the example I provided.
Great, thank you. We have a couple of questions. The first one is, what issues do you see in scaling this passive assessment depression research to large samples or even multi-site studies?
That's actually a very good question. And so I think one of the challenges we had is still with the wearable sensors. Actually, the most of the time during the data monitoring or data collection, we spend a lot of time training people or dealing with certain technical problems with the wearable sensors. So I don't think yet the technology, at least the one which we used, which basically requires passive data, is yet at the stage where we can widely scale it. And as well, there's a certain cost associated with these devices, which I think it has to be reduced in order to be widely available, really. And the last point, which I think is one of the biggest challenges, and we are missing methods in this domain, is how we can remove the noise from the data. For each modality, so if we take heart rate or ectodermal activity, has its own challenges in terms of how we can remove the noise. But there is a huge difference between the studies in a lab versus in the real world, especially related to the noise removal. So I think this is one of the challenges which we need to, or community need to look into more closer in order to make it, widely available, I think.
Okay, thank you. The next questioner says, I may have missed it, but can you predict resolution or improvement as well as the presence of depression? And if so, which features identify people likely to improve?
So resolution in terms of how accurate it is, or how often we can assess it, because it could be two things if I understand correctly, right? So in terms of the time, like how often we, in our case now, in our current study, we make clinical assessments more often. It's now on a weekly basis, and that's why we collect PHQ-9s on a daily basis. So we will be trying as well to look, can we actually monitor it on a daily basis to depression versus like it was every other week in the study. Now, in terms of the accuracy resolution, so I think there is already a challenge with the actual baseline collection. So there's, in terms of the accuracy, how clinicians assess, there's certain resolution, and I think there is a agreement between the clinicians, which is around 80 or around 80% or so, So we cannot really, we would be basically tracking specific clinician versus actually tracking the depression. So this is another challenge here. So I don't think in terms of, we are trying to improve the accuracy of assessment, but I think there's still potential to improve it.
And I'll give people a chance to type in some more questions. I guess another question I had was, maybe it's more of a comment, like, can you talk a little bit more about how this can be used for really just-in-time adaptive intervention? So you could be delivering an intervention, you know, using a mobile health platform, and it could agilely adjust depending on the passive assessment, of course. And you know, to what degree do you think the sensitivity could it be sensitive enough to detect the small changes and then respond to those changes in a proper way with AI?
Mm-hmm. Yeah. So first, in our approach, we would like that this is a solution which still involves clinician. And I think what is very interesting, or information which is missing for the clinician, is that they do not necessarily know what is going on with the patients in between the visits, except for what the patient tells them during the interview. So that's why we built this visualization platform, so that they could identify specific aspects of depression which needs to be addressed. And in terms of how it would work, or how I would imagine in the future, is that the clinician can look at the data and he can or she can identify more accurately what is the type of the depression based on the symptoms which are already aggregated and presented to the person, to the clinician, in a very easy way for him to or her to interpret. That's how we imagine this would be in the future. And secondly, we hope that this technology can eventually send some triggers to the clinician if certain symptoms are aggravating, so that he or she can meet with the patients much earlier than another, I don't know, month or two when it has been planned. So this is the you know, where we, at least the near future, how we see that is that in the future we can imagine that the doctor would be able to see on the dashboard the specific symptoms related to depression, how they are objectively developed throughout the time since the last visit. And secondly, it might trigger as well certain notifications to the clinician in between the visits if something is going wrong with the patients. That's how we think would be the two kind of changes.
Yeah, or the phone can deliver a self-management strategy until they can go see their clinician.
Oh yeah.
Mm-hmm. Based on very before the person's even aware that they're becoming depressed potentially, right?
Yes. So. Yeah, exactly. That's why for us the physiological measures are very important. Well, actually, we have recently looked into circadian rhythm. I didn't present it, but we see already some trajectories in circadian rhythm related to ETA and activity, which we hope or might be actually visible prior the actual symptoms related to activity or so is already visible outside. Yeah.
One more question from the audience. Can he speak more to the trust level people have in passive monitoring devices, that they are measuring what they're supposed to be measuring?
Yeah, I think that's a very good question. And this is one of the challenges now that the community is trying to address is, basically, I imagine this is a question about the privacy. And especially in the second study, this was a bigger challenge. Not in the first one, because patients, I think they had trust because they were actually patients of a hospital and they had a trust to the institution. Whereas in the second study, it was more challenging because it was done with the company. And this is an obvious question. Would you be willing to share your own personal health data, and especially when it might be related to your mental health, with your employer? So in this context, the way we set up the study is that we only, as researchers, had access to individual data, and we were only sharing the aggregated measures with the company, like summary of a group of people, so that they cannot really identify individuals' data. And in this context, we generally had a good adherence, and people in terms of the questionnaires, I cannot really say how honest they were with us, but in terms of the adherence to the surveys and as well to the devices, we didn't see any significant drop from our other studies. Yeah.
Okay. Great. Thank you so much, Dr. Fedor. It was really fascinating, and wish you good luck with the next steps of your research. Now I'd like to turn it over to my co-organizer, Dr. Quintiliani, who will introduce our final speaker of the day.
Thank you so much. Bye.
Hi, everybody. Welcome back from the break and after our third presenter. Thank you so much, Professor Fedor, for that exciting talk. I am here to introduce our fourth and final presenter, Dr. Audi Atienza, who is a senior program officer at the National Center for Advancing Translational Science at the National Institutes of Health. Prior to joining NCATS, Dr. Atienza served as a senior program officer at the National Institute on Aging and the National Cancer Institute. He's contributed to various NIH-wide research efforts, including the NIH Roadmap Initiative, NIH Genes, Environments and Health Initiative, the mHealth Summit, NIH Big Data to Knowledge Initiative, and the NIH Researching COVID to Enhance Recovery Initiative. He's published over 70 scientific papers and has led multiple public-private partnerships to advance digital and mobile health. This talk is digital and mobile health technology for research, for health research, nice toys, or game changers. Really excited to hear your talk, and thank you so much for joining us today.
Great. Let me see if I can get my, can you hear me? Great.
Yes.
And can you see my slides?
Yes.
Great. So let me put this on full screen. Okay, can you see my slides now?
Yep. Looks
Great.
good.
So thank you for the invitation to speak at the symposium. I appreciate the kind invitation from the organizers and the kind introduction. I am Audi Atienza. I'm a program officer at NIH. And this presentation, I'm going to give a 30,000-foot view of digital and mobile health at NIH. And I'm also happy to go off script and talk about NIH funding or policy issues. So feel free to ask questions about funding and policy if those issues are of interest to you. So the obligatory disclaimer, the views expressed here do not necessarily reflect those of HHS, NIH, or the National Center for Advancement of Translation Sciences, NCATS, nor the federal government. And with that disclosure, I will continue. So anyone who knows me knows that I am a huge Star Wars fan, a Star Wars geek through and through, and proud of it. And as I think about mobile health, the Star Wars droids actually offer a nice metaphor for how mobile health has developed, and as we as the research community strive to build. So, you know, the first droid that is a fan favorite of Star Wars fandom is the Gonk Power Droid. The Gonk Power Droid isn't very fancy, it's rather clunky, but it actually gets the job done. So the next is the protocol droid that is fluent in over 6 million forms of communication, C3PO. It's more advanced in AI than the Gonk droid, but you know, to tell the truth, it's fairly limited. C3PO freely admits that he, she, they, it is just an interpreter. And I'm going to express the quite unpopular opinion that besides being a translator, C3PO is quite useless, actually. And he or she can't keep a secret. So security is a problem for C3PO. And then there is the hero of Star Wars, in my humble opinion, the astromech droid R2-D2. R2-D2 can do it all. Can keep secure information, transmit it to those who need it, can connect to centralized computer and gather real-time information to save lives, and can optimize other systems. So R2-D2 basically, in my view, is the game-changing technology here. So I am not here to knock the Gonk droid. I actually think the Gonk droid has a purpose, and I've done my share of developing Gonk droid research. Actually, early on, I worked with Dr. Abby King and BJ Fogg and Christopher Gardner, and we were building the Gonk droids, and rather simple technology that's not very complex, very simple functionality. But keep in mind, this is before smartphones were actually invented. They didn't exist yet as we started this research. We launched, this research around 2000. iPhones were launched in 2005, and back then PDAs stood for Personal Digital Assistants. Those are the Palm Pilots and the Cassiopeias. So one day I turned to Abby and I said, "Hey, holding my proud Palm Pilots in my hand, and I said, hey, wouldn't it be cool if we can use this cool new tool, this toy, to collect cardiovascular risk factors and health behaviors in real time?" We connected with BJ Fogg, who was teaching at Stanford and had a side gig at Casio and working with Cassiopeias. And we pulled in Christopher Gardner, who was doing some diet research to add to the physical activity research that we were doing. And the rest is history. So I think, the development of foundational research is important in building these technologies. But as I moved to NIH, I saw the power of convening stakeholders, and I've seen mHealth evolve in the exploration and development of mobile and digital health technology. You had Bob Croyle at NCI, just a visionary for looking at health behavior research and technology. And he challenged the community to delineate the science of real-time data capture. So the stuff that Eric Heckler was talking about with adaptive designs and micro designs, those actually really got started with Bob Croyle pulling these stakeholders together and saying, what can we do to accelerate the methodology? And then Bob said, hey, what if we integrate these technologies into patient-centered care? What would that look like? And how can we develop the science around that? A few years later, Francis Collins, fairly new to being the director of NIH, he brought industry, nonprofit organizations, and federal government agencies like NIH together to explore how we can work together to accelerate and advance research in mobile health. And we held the first mobile health summit actually in 2009 and had a big shebang in 2010, bringing in Microsoft, UN Foundation, and many others, including SEC, FTC, and others, to talk about mobile health. A couple of years later, the Secretary of HHS, the Honorable Catherine Sebelius, and the CTO Todd Park with Greg Downing said, well, that's great, but there's this thing called open data that we want to see if we can get scaled up, and can mobile devices collect data, make it open, and can it be integrated with other data systems? And so it's a brief history of kind of how this has developed in the federal government. And as we saw, I was recently at the most recent Health Data Palooza, and these issues of scalability, of interoperability, of integrating with healthy data systems are still going on, and they're really important issues to discuss. So in essence, we've moved from developing Gonk droids to developing technology that integrates with medical systems, to mobile technology that integrates with many other different systems. So in 2011, Kevin Patrick, another visionary of health technology at UCSD, pulled me aside and said, this mobile technology stuff is really, really interesting. And it has the potential to really scale the adoption of health IT. But what are the challenges? And can we delineate this? And so we wrote this thought piece. And we basically argued that mobile technology will be the game-changing technology to drive the adoption of consumer-facing health IT. And it only took a global pandemic, actually, to show what a game changer mobile technologies can be. And we outline these following challenges and that deal with standards, with safety, with privacy and confidentiality, with security, with access to these systems and the effectiveness of the technologies. And in essence, we were addressing these issues of building an R2D2. That's what we are asking. So in essence, in order to establish these interoperable systems, you have to address each of these elements. So now I want to discuss actually what is happening now at NIH in mobile technology. And there's actually a whole lot happening. There are 27 institutes and centers at NIH. So I won't be able to talk about everything that happens because there's so much happening. I'll only be able to talk about the major initiatives and provide some key examples. But with a lot of these cool tools that are being developed and studies that are happening, I want really to ask, are these the droids that we are looking for? And I'll let you decide for yourself. I do want to note that many of these things I'm going to be showing you are being developed now and are being run now. So they may not have the data to show the effectiveness, but it shows you what is actually happening across NIH, trans-NIH efforts, and other really cool tools. So let's get started. So it's clear that digital and mobile health technology is important, and it's a cross-cutting issue across NIH. In 2018, NIH released the first ever strategic plan for data science. And in this plan, mobile technologies, including wearable devices, are called out specifically as tools for broader use. So this is an important issue, data science and the use of mobile technologies in health research. So with respect to some of the major initiatives, there is the HEAL initiative, there is RADx, there is NIH Toolbox, there's All of Us, there is Recover. Each one of these major initiatives that have millions of dollars, sometimes billions of dollars invested, have incorporated mobile technologies. Again, I must note that the data on the effectiveness of technologies are not yet available in many cases. So I'll only be able to talk about what is happening. So let's start with the HEAL initiative, the Helping to End Addiction Long-Term Initiative, HEAL. Is a trans-NIH effort to speed scientific solutions to stem the national opioid public health crisis. And in this initiative, one of the FOAs that was released really was looking at developing technologies, interactive technologies, to assist the participants and patients with medication treatment advancement. And this study by UCLA is doing exactly that. They have created an interactive text messaging app, I am free, quite clever, messaging free, for opioid use. And so you can take a look, there's the website there, really cool stuff to see, can you enhance the engagement of participants as they are going through medication therapy. The next thing I was going to highlight is the mobile toolbox for assessing and monitoring cognitive functioning and cognitive decline. So this has been developed, initiative developed by the National Institute on Aging. And this tool is, and these tools actually and methodologies are available on smartphones and tablets and provide sensitive and accurate measurements of cognition digitally. And why is this important? Well, it's important because the rates of Alzheimer's disease and related dementias, ADRD, as we say, is growing. There's currently estimated 6 million Americans with ADRD, and it's expected to grow, I think, to 13 million by 2025. So establishing reliable tools that can be used and can capture real-time data is important. And these tools are currently being assessed and studied for their effectiveness in assessing RDRD. And they're basically neuropsych tests that you can use on your smartphone. Cool stuff. The All of Us Research Program. This is a huge initiative. It's very ambitious, longitudinal studies that's recruiting 1 million participants and collecting clinical data, behavioral data, genetic data, biological data, healthcare data over time. And mobile technologies have been integrated into this study. Smartphones, commercial wearables, they're assessing not only health and measurement health, but also they're being incorporated into enrollment and e-consent and participant engagement. So the All of Us Research Program, they're collecting wearable data using a BYOD policy. So technology that some already have in their homes, from Apple Watches to Fitbits to Google Fit devices. And they've piloted a program to purchase and distribute wearable data to some participants that may not even afford it. And so the issue that Eric Heckler was talking about the digital divide and making sure that we don't enhance or make that gap wider, the All of Us Research Program says, you know what, let's not make technology the barrier. And so they've connected over 40,000 wearable devices to the All of Us Research Program as of April 1st, 2022. Pretty cool stuff. And then this thing called COVID-19 pandemic happened. And I don't know about you, but it shifted all of my things to digital and mobile technology. For the past 2 years, I've been working remotely, everything from work to entertainment and even sometimes healthcare with telemedicine, telehealth has gone digital and mobile. And you see these trends in the proliferation of development and adoption of mobile health in the research. Zhang and colleagues documents this exponential development of infection-related apps before and after the pandemic. And you can see broken down by Apple Store in blue and the Google Store in orange. And taken together, people see the benefits and the utility of using mobile devices to get information about COVID and possibly get treatments or connect with providers via mobile. NIH recognized the importance of digital health early on in the pandemic, and through the Rapid Acceleration of Diagnostics, or RADx initiative, they put out calls for digital health solutions to COVID-19. You know, they put money where their mouth is here and saying, we need some devices that can really help us out and provide evidence-based, research-informed technology. Most relevant here is the RADx Tech portion of the RADx program and the RADx Radical. And I'm going to highlight some things that have been developed as a part of these initiatives. So RADx Tech, it asks for innovative point-of-care devices and home-based tests for managing population health and individuals' lives during the pandemic. And the premise here is to leverage digital health technologies, smartphones, smartwatches, Bluetooth thermometers, Bluetooth pulse oximeters, et cetera, to help us manage our response to the COVID-19 pandemic. So here's some of the cool things that are developed in 4 different areas that were funded. They're wearables for monitoring and detecting COVID-19, digital contact tracing, the integration with test results, and proof of health status. And again, I can't go through all of this because of time, but using physiological monitoring and wearable devices and monitoring sleep and activity, you know, PhysIQ and Evidation have developed programs using machine learning to see if they can detect and monitor what is happening with respect to COVID infection. as we look at, I was going to run through these, the digital contact tracing, there are 3 awardees, IBM, UCSF, Vibrant, that's using GPS systems and Wi-Fi technology to see if somebody has been in contact with others who may or have a high probability of being infected. And with respect to the integration of test results, the NIH is working with the Gates Foundation to develop technology to look at reading test devices in home test kits. And with respect to proof of health status, iCrypto is using blockchain technology and using these smartphones to let people know about if you have a reliable sense of whether somebody is infected or not and what their health status is. You know, NIH is actually doing something within NIH for the NIH employees in Safer COVID. And Safer COVID is a program that allows NIHers to track their vaccination status, to track their symptoms with daily surveys, and gives the NIH community an indication of whether the individual is safe to be returning to work. So a lot of real cool things happening in that have been incorporated in the NIH organization community. RADx-RAD is technology that is out of the box thinking. Some of the things that have been produced out of RADx-RAD you probably heard of, such as wastewater treatment detection, but they've also looked at developing mobile and portable technologies. And one initiative is the scanning for COVID-19 with electronic nose technology, the SCENT initiative. And the basic premise behind this is that dogs have much better sense of smell than humans. They're 10,000 times more accurate than humans. And they're powerful enough to detect substances at concentrations of 1 parts per trillion. And to put that into context, it's like putting a single drop of liquid in 20 Olympic-sized pools. That's how sensitive dogs' noses are. And so the idea is, can you reverse engineer a biomimic of sense to detect COVID-19? And dogs have been trained to detect other diseases, diabetes, cancer, and other things like that. So the idea is, can we do that? And so NIH is funding 4 different teams to do exactly that, to look at chemicals and also gas chromatology, as well as look at volatile organic compounds in the skin. And these are mobile technologies that are able to detect different types of chemicals. Again, we'll see how effective they are, but it's promising technology. The NIH Recover Initiative. Everybody's heard of long COVID. These are persistent symptoms that can last several weeks or even months after the initial infection. And Congress gave us $1 billion to understand what is happening, because we don't really know what is causing these long-term symptoms that can be debilitating. And as part of the Recover Initiative, we have incorporated mobile health technologies, a mobile health platform. And you can see what capabilities we're looking at as we want to facilitate the collection of data, collaborate, have a platform so that researchers can collaborate. We want to be able to integrate this mobile data with other cohort data, genetic data, other sources of imaging data that has been collected as part of the larger cohort initiative, Recover Initiative. It is a very ambitious undertaking. And we want to send that information to a mobile health data repository that can harmonize data, that can curate it, that can aggregate it, and make it usable for recovery initiatives and ultimately the research community. I was hoping today to be able to announce who the awardees are because we're just about to make that announcement, but stay tuned because it is really exciting what we're planning for this. Again, we're looking to study over 20,000 participants in the Recover initiative and incorporate these mobile technology in this. And there's going to be clinical trials as well that will be looking at treatments for those who are experiencing long COVID, or we call it PASC, post-acute sequelae of SARS-CoV-2 infection in NIH speak. So stay tuned to see how the mobile technology is incorporated into the clinical trials. Now, this is what I call a horrendogram. The horrendogram shows the data flow of Recover. It's a schemata of the data flow and lots of details here. And looking at FSMA moderate data repositories and how data goes from those to the data research core, how the researchers interact with the clinical science core that is putting together the different standardized measures. But what's important here is you see that the mobile health platform and the mobile health data repository is in the mix here, and an important aspect of the data architecture of Recover. So I would be remiss if I didn't talk about the CTSA program of NCATS. I come from NCATS. I'm a program officer here. The NCATS CTSA program is a consortium of 61 centers, we call them hubs, and they're funded to speed the translation of research from discoveries into improving patient care. The unofficial model for NCATS is that we aim to get more treatments to more patients more quickly. That's what NCAT was established to do, and when it was established as an institute and center. So continuing with the COVID research theme, one of the hub Scripps Research Institute, they conducted this really cool study fairly early in the pandemic in which they used smartwatches to better detect infection. So working with Care Evolution, a company that works with mobile devices and has a secure data platform, they basically found that if you use smartwatches, in addition to self-reported symptoms, you're better able to detect who is positive for COVID-19. And these, I believe they use Fitbits here. And so it is, commercial available technology that can scale. Scripps also did something really cool with patches. They used a Zeo patch in which they looked at atrial fibrillation. And what was really interesting about the study is that it is a siteless clinical trial with a health insurance group. And they basically found folks who were potentially eligible in the health insurance plan who were at risk for AFib, high risk. And then they randomized them to two groups. One group was using the Zeo patch, and then for 4 months, and then the other one was a waiting list control. And what they found using this technology of over 2,600 folks was that using the smart patch, they were able to diagnose those, provided a diagnosis of AFib more quickly for those who are at high risk after 4 months. Really cool technology. University of Rochester is looking at using smartphones, wearable sensors, and home sensors to develop a clinical phenotype for Parkinson's disease. Basically, they want to see how Parkinson's disease affects individuals in their everyday life and come up with a characteristics, a clinical phenotype of what's happening with Parkinson's disease patients so that it can look at how they can intervene later on. The University of Georgia, CTSA, has created what they call a hatchery, and it is a service to the researchers in the consortium to learn the ins and outs of developing and testing mobile apps. It's a great training tool and a great service that is provided for this Georgia consortium. And they don't provide coding, but they show how they walk the researchers through what it would take to develop this technology. Another researcher at Georgia, Wilbur Lamb, he mentored two scholars, Robert Minioli and Erica Dybersky, and they were recognized as 30 of the Forbes 30 under 30 top young entrepreneurs in the development of the AminoCheck mobile device. And basically what this technology does is you take a photo of your fingernail and it gives you a sense of what your hemoglobin levels are and whether you're at risk for anemia. Amazing stuff. Again, this is stuff that the CTSA program helps to enable. And then finally, the UCSD group, they're creating something really cool, a smart bandage that collects physiological data and electrical signals. And it's Bluetooth equipped. And the really cool thing about it, besides collecting electrophysiological data and temperature, is that because it's Bluetooth enabled, you can basically control a robotic arm with this technology. So really cool stuff. I'm from NIH. I want to say we have money. There are funds available. I highlight some of the active FOAs that are relevant to digital and mobile technologies. I encourage you to take a look at them. The links above are links to the general funding opportunities as well as the SBIR opportunities. I always say in every talk I give as a program officer at NIH, the best thing you can do as a researcher if you're looking for funds at NIH is talk with a program officer before applying. Talk early and often. That's why we're here, and we can help guide you through the process. So I'm happy to talk with others, even after this presentation, about funding opportunities at NIH. So how am I running on time? I'm a little behind, but there are challenges. Cool stuff being developed, but several challenges remain. Privacy and confidentiality is a stickler. And I want to point out this issue with consumer wearables. And I actually was talking with the breakout session about this a little bit. These issues are thorny because if data is collected and it's in the data repository of the company, you really have to understand what the terms of service are and the agreements you are making, the individuals are making in using this technology. For example, Fitbit and Apple, if you look at their terms of service, they basically says they can use your data for whatever they kind of want. Apple's a little bit better than Fitbit, but Fitbit basically says we can use your data. So this conflicts with the common rule. And if you're looking at to issue certificates of confidentiality, you want to make sure that the data is in repositories that you control. And saying that that data that is in your repository that may be in a FISMA moderate environment, that data is bound by the common rule and is we control it and we can issue certificates of confidentiality. But the data that is in these repositories for companies, it's a problematic issue that needs to be resolved. So, and we always say that, with participants, research moves at the speed of trust. So if participants are not trusting where their data is, then that's a problem. There are measurement issues with consumer wearables. I mean, look at what do the wearable sensors actually mean? What does a step in an Apple Watch or Fitbits really mean? How do they calculate it? And are they comparable? And spoiler alert, the answer is they're different. A Fitbit's step is different from a Garmin, from an Apple Watch, etc. And we have to really understand, really, what are we measuring? Sleep measures, calories burned. And so if you're looking at doing a BYOD strategy in your research, you really want to understand, what are we actually measuring? And if they bring in a Fitbit versus an Apple Watch, what can we really say about these measures that we are including in our research? And what about theory? Back in 2008, Wired magazine threw a shot across the bow. We don't need your stinking theory. We have data deluge. We can do data mining. The research method that it currently exists is obsolete. Interesting article to read. And I argue, no, it isn't. Like Eric Heckler said, we really need to know, not only describe what is happening, but we also understand why and how things are related to each other. And in 2011, I worked with a number of colleagues, some just wonderful folks to collaborate with, to look at health behavior models. And we looked at the current models, we looked at different researchers that are happening, and we said, are the current theories in the models, are they appropriate? Are they adequate? And short answer is no, they're not. We really still, at this time, 10 years later, we need to expand these models and make them relevant to the data that we're collecting. So, where are we? Here's my very unscientific assessment. We've come a long way, but we still have a long way to go in realizing game-changing mobile technologies that can really accelerate the pace of health research. And, you know, I say we're not quite at the R2D2, we're maybe at the R5D4 droid, advanced technology, but not quite as game-changing, and sometimes it malfunctions. But I put this question of toys versus game changer, it's false dichotomy. It's just more to be provocative. We actually do need these Gaunt droids and the mouse droids. We need these technologies to do specific tasks. But I'm arguing here that if we really want to make game-changing, paradigm-shifting research, we have to address each of these issues. If we want the R2D2 to make research quick, expedient, and sound, let's focus on advanced AI, access enhancement systems, interoperable data, etc. Thank you.
Thank you so much for that presentation. I learned a lot about the scope of all these different initiatives, and it's just so exciting to see how mobile and electronic health is being incorporated across all these different health conditions and initiatives. So thank you for that. We have a few minutes for questions, and I would like to kick it off by seeing if you have further thoughts about a lot of the programs that you mentioned are connecting people to technologies that haven't been previously connected. And I was wondering if you could talk to how that experience is going. I know it's across lots of different organizations. Can you speak to that at all?
So let me see if I can reiterate your question. So many of these initiatives are taking technologies that maybe haven't been used for that purpose, using it with particular patient populations and connecting them to other health systems or other databases and health systems. Is that your question?
Yes, I think particularly in the All of Us initiative, many people who didn't have devices connected now do.
Yes. So it's a bit like shooting at a moving target. So the technology is moving so much quicker than the research can evolve. When the All of Us research program was first conceptualized, these issues of having multi-sensor devices that can have machine learning and AI to address sleep and other aspects weren't even conceived. And as we move towards the further development of the All of Us research program, we're playing catch up to this evolving technology. The hard part that, and it's not a research issue, it is a participant trust issue, is really getting participants to trust that this technology is reliable, that we're keeping their information secure and safe, that we're not sharing the technologies, that the way we're using the technology is easy and non-burdensome to them. So those are some really major issues. And we'll likely see some of these issues with the Recovery Initiative as well. Do people really trust that we're collecting this technology in a way that's in their best interest, that is secure, and that they are able to trust what we're doing with the data?
Well, thank you very much. It was a very enlightening talk, and thank you for joining us today. I really appreciate it. Okay, well, we are in the final 10 minutes of our symposium today, and we have just a few concluding remarks to wrap us up. Okay, so I'm just going to speak about them. So my takeaway from today's presentations was really this issue of trust. So Dr. Atienza just told us this amazing quote. So research moves at the speed of trust. And we see this throughout all 4 presentations. Heather Cartwright's talk at the beginning talked about how patients need to trust that their use of the data in the cloud will be private and secure. Dr. Heckler's talk had a similar theme. If we can convince participants that the data in the research trials that we're running can benefit them in terms of improving the public's health in ways that really will matter to their social context, we will only be building public trust. Dr. Fedor also had similar themes where we need to make sure that the devices we use are safe and secure and people trust in their use, and they'll measure what we say they're going to measure. So I wanted to wrap up by saying I really appreciated all 4 talks, and I'd like to turn it over to Dr. Borrelli for her concluding remarks.
Yes, thank you, Lisa, and thank you to all the presenters. Such exciting, stimulating scholarly talks. It made me think of how these unfortunate events can lead to quantum change, not only in technology, but also in acceptance of the technology. I mean, World War II example, radar, microwave ovens, and synthetic rubber got invented because of that unfortunate event. And now with COVID, we've had, quantum changes in remote monitoring, data science, interoperability, passive and active data collection, and agile interventions and artificial intelligence. And all of the speakers kind of talked about those issues today and the advances in those issues. And it made me think, I was at a meeting, the MEARC and Harari 3 years ago, and they're like, what do you want? What do you dream of, Belinda? I'm like, I really want, passively collected mood and depression data. And it's here now, so, I think what it taught me is that you can dream and then realize that dream. So anything that you feel like would improve our science or your own lives, it's time to do it, because we can, especially when we're forced to under conditions of COVID or other negative conditions. So let's dream under the more positive conditions. And I'll hand it to Eric.
Okay, thank you, Belinda. I want to start off, first of all, just by thanking Lisa, Nicole, and Basia, and Belinda, and everyone else who's helped to organize this symposium. I think it's a fantastic convergence of all these different areas that are really necessary for us to move forward, as Belinda is saying, in sort of a quantum leap. on this problem. I was also very struck by what Dr. Atienza was using as analogy there of trying to hit a moving target. If I step back even further, viewing it kind of objectively for all the fields, you know, it feels to me like what we're watching is different areas, different stones thrown in the water with different ripples, different ways. So some of them are moving very quickly, some in certain directions, some are moving at a different speed at other directions. And we're looking for that magic spot where they all come together. And it's things like the ME-ARC and like Harari's focus research programs that are really designed to try and give people an opportunity to have those conversations that are needed in order to calibrate the speeds, calibrate the language, and all of that. So it's really been a delight to watch the people this past year in this focus research program, and it's really been a pleasure watching to see all the results that have been attained, and also the moonshots that we're still aiming for in this area. So thank you all. Back to you, Lisa.
Thank you, Eric. So I wanted to wrap up in our final minute by thanking my co-organizer, Dr. Borrelli, as well as all of the people from the FRP and MER community that co-sponsored this talk, this symposium. Thanks also to Dr. Ravine and Dr. Kolachik, who lead the two organizations that fund both of our organizations, the ARC and the FRP. Thank you to our four presenters, Heather Jordan Cartwright, Eric Heckler, Simon Fedor, and Audi Atienza for your inspiring presentations. This symposium would not have been possible without the support of numerous people, including Emily Jones, Gina Mantica, Catherine D'Angelo, and Marion Flanagan. A quick note here that we hope the collaborations that may have been inspired by today's symposium can continue through the ARC and the FRPs, and we look forward to fostering those to our respective organizations. The Harari Institute's next symposium will be on the topic of advancing public health with systems science and simulation modeling, so keep an eye out for that on June 6th. And finally, here are social media handles to connect with the Harari Institute. And thank you very much for joining today, and I hope you have a great rest of your day.
Thank you, everyone.